Welcome, everyone. My name is Natalie Wagner. I'm an education developer with the Office of Professional Development and Educational Scholarship, or OPDES. And on behalf of the Planning Committee from Regional Education and OPDES and UGME, I'm thrilled to act as the MC for this morning's session. To begin, I would like to acknowledge that Queens is situated on traditional Anishinaabe and Haudenosaunee territory. And as an uninvited guest on this traditional territory, I'm extremely grateful to live, learn, and play on these lands. I'd also like to acknowledge the many traditional territories that all of us today might be joining from as we come together in this virtual space. And if with everything going on in the world, I also wanted to just take a moment to reflect on the privilege that we have to be able to connect today as a community and learn and share in a safe space. And recently it was shared with me at a session, a quote from Robin Wall Kimmerer's book, Braided Sweetgrass, Indigenous Wisdom, Scientific Knowledge, and the Teaching of Plants. And one particular quote really stuck with me, so I was hoping to share it today to start off our session. In the words of Robin Wall Kimmerer, even a wounded world is feeding us, even a wounded world holds us, giving us moments of wonder and joy. I choose joy over despair, not because I have my head in the sand, but because joy is what the earth gives me daily, and I must return the gift. I hope with that quote and small reflection, we can take with us this idea of choosing joy and giving back as we learn and sort of work through this session and then move beyond the session back into our daily lives and clinical work. So with that in mind, what are we hoping are going to be a few of the key takeaways? Some of this content might be new to you, some of it might be a review. We're sort of very welcome and open to everybody, but we're hoping by the end of the session, we will have provided you with some content so you'll be able to discuss the key considerations for teaching in a longitudinal integrated clerkship, or LIC. Be able to apply principles of layered learning when simultaneously teaching learners at different levels in the clinical environment. Be able to describe the meaning of learner-centered teaching and apply best practices in clinical teaching. Identify and apply key strategies for navigating difficult conversations with learners. Discuss cultural considerations for trainees working in Indigenous communities. And to collaborate with community preceptors from different locations to build a sense of community. I'm thrilled that we have a really exciting agenda for the morning with some wonderful speakers. So following this, we will start with an introduction activity that's sort of introducing all of you and where you're tuning in from. And I'll have my colleague Kate Rombo lead us through that activity. We'll hear from Dr. Sanfelipe from undergraduate medical education, and then we'll pass it over to Dr. Watson, who will speak to the introduction of LICs. Dr. Kenny will speak to layered learning. Dr. Ward will speak to learner-centered teaching. We'll take a brief break and then come back and hear from Dr. Euler about difficult conversations. Then we'll hear from Dr. Horn on cultural considerations for trainees working in Indigenous communities. And then you'll hear from me again, just as a wrap up at the end. There will be a Q&A session or a short period at the end of each talk. So we encourage you to engage during that time, ask questions, raise your Zoom hand or your hand, or type your question in the chat, and we're happy to answer that. And just so you all know, the session is being audio and video recorded. So it'll be shared back with all of you here today, but also be shared with some of our colleagues who maybe weren't able to join us live. Before we move on, I also want to say that it's really exciting, and I'm happy to announce that today's session is just one of many initiatives that the Regional Education Office and OPDES have underway to support clinical educators and preceptors working in the community. Over the next several months, we'll be sharing a number of resources, including online modules on topics like the ones covered today, as well as other topics like the flipped classroom, and a guide on how to use Elentra to complete clinical assessments for learners in the clinical environment. It's our goal that we'll really be able to collate these resources into one easily accessible platform for you. We do have a survey circulating at this time, inviting feedback on what educational resources you think would be most useful. So if you haven't filled that out yet, we would really love to hear your feedback, and I'm happy to share the link in the chat later this morning if you haven't received it yet. With that, I'm actually going to pass it over to my colleague, Kate Rombo, who's a health education associate with Optes, and she's going to introduce the next activity. There you go, Kate, go ahead.
Good morning, everyone, and welcome. It's really nice to see all of you, and we're really excited that you have been able to join us today. So what we would like to do for a few minutes anyway, and then it can continue beyond this session right now at this moment. So what we're going to have you do is introduce yourselves using an interactive map. So I've shared the link for the interactive map in the chat. So I'm going to share that now with all of you. It's a clickable link. So if you navigate to the chat in your Zoom screen, you will see the link in the chat. And if you click on that link, it will take you to our interactive map. So Natalie is going to share her screen, and she's going to show the map. So this is our interactive way of introducing ourselves. So what we would like everyone to do, if you are interested and feel comfortable doing so, you're going to click the pink plus button or plus sign at the top right of your screen. And that's going to allow you to search your location. So Natalie is demonstrating right now that she is searching for Kingston, Ontario, and then she can actually also include her name. If you would like to include your first name and your last name, feel free to do so. Your first name and your last initial would be fine. And if you're not comfortable sharing your name, that's fine too. And then Natalie is going to click publish, and where Natalie is joining us from is going to appear as a little location indicator on our interactive map.
Great, I think that we're all done with this, so I'm just going to switch back to my slides. And I'm just thinking in terms of timing here, if we don't have, I was just thinking maybe, Dr. Watson, if you don't mind, maybe we'll move on to the introduction to LICs. And if Dr. Sanfelipe is able to pop in, I know en route to hospital and things, then we can maybe pause and make sure he can give a welcome. But if you don't mind, that would be wonderful.
Happy to. Hi, my name is Shana Watson, and I am the integrated course director and work closely with Dr. Gillian McLean as clerkship directors as well. It's my pleasure to talk to you with an overview of what longitudinal integrated clerkships are. And I love this picture of Lauren, who was one of our integrated clerks in Brockville, and this was taken right before the pandemic hit. And as teachers and community faculty, I think everyone is familiar with the joy of watching students grow to inhabit the full space, and this picture is emblematic of that. So I'm going to just give a little bit of an overview of what LICs are, how they might be different from the core blocks that you would have experienced as a clerk yourself, and briefly touch on the literature and our experience with LICs, and just highlight the range of integrated clerkships that we offer here at Queen's. Thanks. So what is an LIC? At the bottom here, there's a link, like a little URL to Click MedEd, and Click is the Consortium of Longitudinal Integrated Clerkships, which is an international organization of schools offering this type of clerkship opportunity. And so there's a shared understanding of what these are. And they have a lot to do with continuity for students with preceptors, with place, and with patients. And so within that continuity, students are able to meet the majority of their core clinical competencies across multiple courses simultaneously. So in a traditional clerkship, students are doing one thing at a time, but in an LIC, students are doing many things simultaneously. And I think the real magic happens because the students are given a meaningful role on the healthcare team, that students are known and get to know the people and the system. And I think this is very meaningful for everybody who's involved. Thank you. And when we think about a clerkship offered as a block rotation or an LIC, really they are two halves of a whole, two sides of the same equation. And I might make a pitch that an LIC has some superior options, but the truth is there's strengths in both of them, and through offering clerkship in two different models like this, we're able to meet the learning needs of a whole variety of students and also build on local capacity and expertise and opportunity. Thank you. And so from an educational perspective, the course requirements are the same wherever a student completes their clerkship. They're the same for core block and LIC, and the assessments that students and assignments, exams are all the same, no matter how students enjoy their clerkship. Things that are different are the timing and the order of things. This maybe tells you how my brain works, but this is a graphic really to illustrate the difference between a core block and an LIC. And so the squares at the top really are the objectives and course requirements, the mandatory encounters, the assignments for each core block. And below it, the rectangle represents the body of clinical experiences and patients that a student will see to satisfy those requirements. And we see that the objectives for each course are very distinct from each other, and as are the patients and clinical experiences that students have to satisfy those requirements. The surgery objectives are satisfied by having surgical experiences and seeing patients in a surgical context, and there's not much cross-pollination with their internal medicine or psychiatry experiences. Yeah, thank you. But when we go to an LIC, it kind of turns it all on its head. And if the star is a patient encounter, perhaps a clerk is working in Emerge and sees a 12-year-old boy with appendicitis, that clerk might have the opportunity to assess that patient in Emerge, follow them through to the OR, perhaps scrub in or work with anesthesia on the case, and follow the child up in the community post-op. And through following that one patient experience in the system, the student not only learns about the system, but also is able to satisfy the requirements for a whole range of courses: Emerge, Peds, Family Medicine, Emerge Anesthesia, all through being able to follow that one patient encounter. Likewise, if a clerk is seeing a well baby visit in Family Medicine, and then starts to observe some things about the parent engaging with the baby, they may also include an assessment for postpartum depression. And so again, the student is seeing a patient ostensibly on one course, but satisfying requirements and applying learning from multiple disciplines simultaneously. And so always we wonder, what does the literature say? And I would say that the evidence from the literature and also the evidence from our experience at Queen's is very robust in favor of these kinds of rotations. And everybody worries at the beginning, are the students going to do as well as their peers in traditional blocks on standard outcome measure, things like exams and the residency match. I think we all know that CARMS is the tail that wags the dog, and so students always want to know. And absolutely, we've successfully matched students from our LICs to a whole range of residency spots. And absolutely, we match folks to family medicine and generalist specialties from our LICs, but we also match students to other subspecialty disciplines. And I think of one student who went to Picton for an LIC thinking that she was going to be a neurosurgeon, and had such a great time. She actually came to reconsider that briefly, and then successfully matched to neurosurgery afterwards. But I think we all know that she will be a much better colleague for having spent time in Picton. We also see in the literature that students who participate and complete their clerkship in part through an LIC are able to hang on to some of that empathy and idealism that shines so brightly when they're applying to medical school. Sorry, if you can just go back. Yeah, I just want to speak a little bit about personal identity formation and the way in which these LICs allow students to really begin to feel like a doctor. And I think you'll hear from some people today about the accelerated pace of learning and functional role that they play on the team by staying in one place for an extended period of time. There's no doubt that LICs are appealing in terms of recruitment and retention to rural areas. And so we see lots of LICs in places like rural Australia to address issues of physician supply and distribution. But we also see LICs, at Harvard and in Cambridge, Mass. And so it is a model that is incredibly malleable and adaptive to community need. These are meaningful experiences for both the preceptors and the students. Okay, thank you. Next one. Yeah. So at Queen's, we're delighted to have 9 LICs. The first, now 12 years ago, launched in Perth. And the 4 speakers we're going to be hearing from today are from four of these communities, and we'll speak to the expertise that exists in all of these areas. Each model is different and draws on local strengths and capacities. So the newest that we're joining today to really welcome is our Napanee LIC that is launching at the end of the month. Next slide, please. This is just a chance to see how not only the timeline of the development of our LICs, but also which courses and clinical experiences occur in each community. You can see that Collingwood and Lakeridge have the students with them for almost, well, Lakeridge for their whole core clerkship, and Collingwood is getting very, very close to that now as well. The other longer clerkship will be Coburg. And I'll say that the Kingston LIC was born out of COVID, really, and so that was sort of a happy accident of COVID, and we are delighted to have Napanee joining the group this year. Next slide. At the heart of this really are the preceptors who work shoulder to shoulder with the students and who are able to know the students so well that they can provide the appropriate next step in their education and challenge and help to foster their growth as professionals. And this is Dr. Ogisto Horn, who we're going to be hearing from later this morning, and Thomas Diamond, who is our first student who actually requested that we begin the integrated clerkship in Akwesasne. But none of this would exist without the preceptors, and they are really the heart and soul of it. So thank you to everyone who's here today as a preceptor. Next. So the key elements are that there's a meaningful role for students on the team and this continuity with preceptors and patients. This is the first cohort of students who went to Bowmanville, and the 1% sign there is being held by Gordon, who matched to the Bowmanville residency after completing his clerkship. And I will say that we've matched students also to the Collingwood residency after being there for our LIC, and we have in a couple of communities faculty now who were once students in those communities. Next. So really, the learning occurs by becoming part of the community. And there is an initial period of disorientation when students arrive where they're trying to understand so many things simultaneously. But once they get their feet under them, they take off at an incredible pace. And the collegiality and the warmth with which students are welcomed by communities really makes all the difference for them. And So this is a screen grab off Twitter. Michelle was in Coburg for much of the pandemic, and had nothing but high praise for the experience. And she went on to match to NOSM for rural anesthesia after spending most of her clerkship in Coburg. I will be happy to answer any questions that you might have about LICs or clarify anything that I said.
Thank you so much, Dr. Watson. So if anyone does have any questions, please feel free to unmute and or raise your Zoom hand or just type in the chat. And we can kind of leave a minute or two to see if there are anything to clarify with respect to LICs.
And I'll put my email address in the chat if anyone has any questions or wants to reach out afterwards. I see Kim Morrison expressing excitement, and Kim, I can only say that we are matching your excitement. We are delighted to have Napanee coming on board.
All right, wonderful. Thank you so much for that. And I think we're just going to flip back next, and Dr. Sanfelipe has joined us. So we want to give just a quick few minutes for Dr. Sanfelipe to give a welcome from undergraduate medical education to everyone tuning in today. So I'll pass it over.
Thank you. Can you hear me okay?
Yes, we can.
Sorry to be late. I was running between offices this morning, but as it turns out, I think it's actually better that I follow Shana, because I'd love to just amplify on a couple of her thoughts and maybe give you a perspective on this that led to the development of these things. Lately I've been reflecting on what's good and what's bad about medical education in Canada as we do it these days, and there's much good there for sure, but I think if there's a couple of failings, one is that we have failed to address sufficiently the needs of smaller communities for physicians that are comprehensively trained and engaged in the care of communities and the role as a community physician in the long term. And the other feeling is perhaps that we have de-emphasized the holistic role of physicians in patient care. And we've become, in medical education, much more adept at training students to deliver treatment-specific care as opposed to patient-specific care, and those are huge issues, and I think it's fair to say that these integrated community clerkships, which, as Sheena said, we began about 12 years ago, were a complete departure from the standard paradigm for medical education, and not readily engaged, I must say, by either students or faculty. But I think they are an evolution in care and in training of physicians that that has been highly successful, and we want to definitely emulate as we go forward. And I'm absolutely delighted to see this developing in Napanee. In addition to the points that Shana raised about how these have been successful academically, I would add a couple of things. One is that the level of student satisfaction, which we gauge at the end of the fourth year, students do this rather comprehensive survey and tell us about what they liked and what they didn't like about medical school. And believe me, they are not shy about sharing their opinions. They tell us consistently that these longitudinal integrated clerkship experiences rate actually as the highest in terms of student satisfaction. So students have engaged them, faculty have engaged them, and as Sheena mentioned, our students are voting by their feet by taking up these opportunities, locally and in other places. The bigger thing, though, that I see, and many of you who've been involved in these before will know what I'm talking about, is a softer thing. What we see is a development and evolution of the student as a well-rounded physician who understands their role and takes on that role in a much better way than they did before. The reality is, our students are coming into medical school young. They're coming in having spent a lot of time preparing to get into medical school, and they're in a lot of ways, not fully baked in terms of, knowing what they want to do in life, or what their skills are and where their preferences are. And these integrated community clerkships provide them that place to grow under the nurturing of the physicians that are there, all of you. And we see it all the time. We see young people who are incredibly bright, incredibly committed, but not yet found their place in the world, find their place in the world. And sometimes we see it in folks who didn't ever imagine that they would want to do a more family medicine-based generalist practice in a smaller community. So that's a wonderful thing to see. Then we see the other too. We see folks who understand that that's not for them, and that's okay also. But the value of these is huge, and it's too much to call. And the role of the preceptors is central to it. There's just no question about it. The relationship these students form with not one, but with the group of physicians in the community, they become part of that. They become part of the community. They bond. They bond to patients in a way that they have not had the opportunity before and would never have the opportunity to get to know longitudinally in a standard block-based rotation. They get to know the people in the community and what their place is. We see that all the time, and it occurs because they're in that nurturing environment. Now, we don't call this apprenticeship, and that would be, believe me, a pedagogically dangerous term to use for any of this. But the fact is that there are aspects of the apprenticeship model that work here. That connection, that modeling of practice, that modeling of life is what works here. So I could go on about this a long time. You can tell I'm quite high on these things. I would love to see us get to a point where where this is a standard component of medical education, because honestly, I think it goes above and beyond. So I am absolutely delighted about Napanee joining. Now, some of you may be aware that in ancient past, I had links to Napanee. When I was training, I did locums in Napanee. I had time there as a medical student. I have, over the years, have enjoyed connections with the community in Napanee, and I think it's a wonderful community of physicians and a wonderful hospital, in an ideal place for this to happen. And I've wondered over the years why this one closest to us, we didn't grab, but I'm just so glad that opportunities come up now. So I'm going to try to stay for as long as I can for this session today. I'm really pleased it's happening. Happy to take any questions or engage any discussion that anyone has, but just let me tell you how valuable we think this is, and I'm profoundly grateful to all of you for being part of it. So thank you.
Thank you so much, Dr. Sanfelipe. I don't know if there are any questions. You can take a minute to pause. We're really grateful to have you here, and thank you for those comments. I think with you and Dr. Watson, it just highlights some of the excitement for this Napanee LIC to begin later this month. So thank you both very much. Next up, I don't see questions right now, but again, if you have them later, certainly put them in the chat. Next, I'll actually pass it over. I'd just like to introduce Dr. Robin Kenny, who's the Medical Director of the Eastern Regional Medical Education Program in the Department of Family Medicine at Perth, who'll be leading us through a discussion on layered learning. And I will pass it. I think we just need to make you a co-host. Jen, if you don't mind, if we can make Dr. Kenny a co-host, and then feel free to share your slides. I'll just close mine.
Great, thank you. I love these Zoom meetings. Hi, everybody. Talking to you from Perth here. It's funny after listening to Shana and Tony talk here. Like, I'm one of the converted, so I've been doing this for 11 years now, and everything they're saying is absolutely correct. The longitudinal clerkship has really changed the game here in Perth. It's not all about recruitment, but it has worked very well in that way. I think more is what it is a culture of learning. And that's what we're going to talk about a little bit in this talk too, is that the culture, having these students there for a long time. I'm going to talk to you about adding residents to the mix as well, which sounds scary. And again, we're asking you to do longitudinal clerkship that I'm throwing on, hey, why not do some more? And during COVID times, I know it's perfect timing. But anyways, we'll talk about it a little bit about that. But you'll see back to this talk that I'm talking about, the culture of learning is super important, and it just takes off on itself. When I started here in Perth with the longitudinal clerkship, I think we had 10 docs in Perth. We just shut down at 24 and we're done. And I'm one of the oldest in town now. I think I'm the 5th oldest doctor in town. Everyone is younger. We have 2 integrated clerks actually practicing here in town. I'm quite proud that I had a time, we're going to talk about with the layered learning, I had of a resident for 2 years through the Ottawa community program. They met my clerk who was here for 4 months, and now they're in practice together here in Perth. And there's just little victories like that, which are fun. They're colleagues now, and I just get to be that old man watching it happen, which is kind of fun. So anyways, this is a recycled talk. I know some people have seen it already. I do apologize about that. Please ask some questions, because if you know me, I'm great in person. I don't like Zoom. And so please ask questions and keep me going a little bit on this one. Sometimes I talk too fast and just shut me up, and I'm okay with that too. Anyways, okay, I'll share my screen. We'll do our talk, and then I'm not going to take all the time we have here. So make sure this works for me. All right, there you go. Can someone give me a say on the chat? You can see that.
Good. Everything looks good.
All right. So I changed that. I used to say WTF instead of really. I changed that for the audience because I don't know you guys as much. So I thought that would be a nicer way to do it. So really, you want me to teach a student and resident at the same time. Okay. So the objectives of this is discuss layered learning and some research that I could find to support it or not. Layered learning by definition, guys, is going to be undergrad and postgrads. This is residents and the undergrads at the same time. I'd love some group feedback about what is working. I'd love some feedback what's not working, and just to learn something to take back home. Okay, conflicts. You have to always tell you conflicts in this stuff. So my conflicts are I'm involved in medical leadership and trying to get people to teach. So I guess that's a conflict. My goal is always to have as many preceptors that want learners to teach as many learners as they want. I know that's a mouthful, but it really is the goal to get the people that are out in the small communities to teach as much as they want to teach. And also opening up as much opportunities to the learners to learn from these preceptors. And that's what we're talking about today with the new LIC in Napanee. Another conflict, and I think it's an important one, realize that our undergraduate programs right now are struggling. They're struggling to place learners as the number of postgrads is really increasing in the smaller communities. We've been very successful in getting funding for residents over the last 5 to 10 years in smaller towns, which is becoming harder to get undergrads in. And I'm going to try to promote that having one or the other doesn't mean you only can have one or the other, and it works really well to have both. So that is a conflict, and that is a little bit of my underlying goal here too. My background, resident, I was in Thunder Bay before NOSM, so it sounds like dark ages now. We're totally one-on-one preceptor-based teaching. That was why we went there. It was just you and the doc, no other learners around at all. I bought in for that. I was site director of the residency program there at the beginning of NOSM. And so when we talked about having 2 learners at the same time, I was quite worried about it. I'd never had that. I was always one-on-one. We didn't have medical students up in Thunder Bay. It was just the residents. And I was quite hesitant, honestly, to have 2. So I guess I should increase that 10 now to 12 or whatever it is. So I've been teaching multiple levels of learners now for that long. Learned a lot over the years, learned what's worked and definitely what doesn't work. I definitely want to promote it. That's why I'm here. I wouldn't be good if I wasn't. And I figured because I had to do a talk about this, I should see if there's any literature on it. And I'm not a literature research guy, but there's not a lot out there, but everything tells me probably should keep going. It's probably a pretty good thing to do. And we'll go through a few of those studies too, very quickly though. Okay, so this is like the ERMEP numbers. This is what we have out in Eastern Ontario. Students got up to 400 months of students a year. Residents were up to 130, where we used to be about 20 to 30 basically when we first started. So that's a huge increase. We have about 35 regular preceptors. So you look at those numbers of months of both in the 35 and you see why I'm talking to you today. And we have about 200 other dogs that teach a month here and there over the year. But there's not a lot of preceptors for all those months that are teaching on a fairly regular basis. Those are just the ERMEP numbers. So this doesn't include Ottawa postgrad, Ottawa clerkship. Most of the Ottawa clerkship does include, and it doesn't include the postgrad from Queens either. So there's more learners out there, but the preceptor numbers really aren't that high. Okay, so here I'm going to stop and have to, hopefully someone's listening. How many of you have taught undergrad and postgrad at the same time? If you could put in the chat or talk, please do. We've got lots of time. I'm trying to use it up here. My talk's not that long. So perfect. So we have a combination of people who have, some who haven't. And I like this so far there, Karen. Thank you. That's nice. So that means I might be able to do something here today. So thanks for that. Then I'm going to ask another question. Second question is, if I can go to thing. Can you give me one thing, if you've taught them at the same time, give me one thing that you thought was helpful? Yeah, we got the resident teach the student. Yeah, ask a resident to supervise and review for sure. Residents love to teach, absolutely. We got a negative here, but space is very tight, and Daniel will talk about that too for sure. Thanks for that. Pyramid scheme, thanks, Shanna. Yeah, that's right. Oh, I think that's important, Tony. You're going to hear this in my talk too. Resident advice to students about the careers, etc. Absolutely. And that's something we're going to talk about too, especially with my conflicts I've already given you guys as well. Good. Yeah, and if you haven't taught at the same time, what are the main reasons why? I saw Daniel already said space, and definitely, and we're going to talk about space in a second as well. Computers, okay. Yeah, so exactly, Kim. I totally get that too. These are all great answers. As you're thinking about this, you're seeing all of it as well too, and that's perfect. Perfect. Okay, let's go through a lit review, and it's going to basically tell us a little bit, or it's going to basically just say what you guys have told me right now, and we're going to chat about that. So I found a few different things here. Here's one: the benefits and challenge of multi-level learners in rural general practice. Interview with learners, staff, and patients, and what they find. Again, the obvious stuff: residents and students realize that they brought different strengths to the team. The residents have better clinical experience. Students have a better grasp on the theoretical aspects of medicine. I don't know if you guys have had both, but it's quite interesting. The anatomy of knowledge of a student is usually a lot better than mine, that's for sure. And it seems to be a continuum of forgetting my neuroanatomy when I was in second year medicine back in the day. Residents found that they questioned their practice and they evolved. They had to justify what they were telling the students. And I think that's really good to do at a young age instead of just always be the sponge taking stuff in. I think that's super important, and it gives you that evolution of your whole career. You're always going to be thinking and doing teaching. I think if you're already at this talk, you're already convinced a little bit that education of students are important, is that it keeps you, my always line is less dull. It makes you think about what you're saying instead of just going through the motions, and they challenge you, and it's important, that's for sure. The students felt more at home, and they felt more at home because it just wasn't one with them. There was someone that was closer to their learning level, more at home. So to ask more questions, they felt more comfortable. And again, at COVID times, it was more social time outside the office. I can tell you right now, the students and residents that work with me here do stuff, or did do stuff before COVID times quite a bit together, which was quite nice for all of us, honestly. It takes the pressure off you as a preceptor about doing all those things as well. Did I miss one there? So I'm clicking on the chat at the same time. All right, perfect. Oh, here we go. So the supervisors, though, it really did and show the importance of the supervisors feeling adequately resourced. And resource in this situation was room, and it was things like computers, for sure. The preceptors had to be prepared for individual learner needs. The objectives are different. And I think this is really important. And I think day one, and I'm going to give you a few tips, day one of having these different level of learners is realizing that. and talking about their objectives of each learner separately. And I think that's it's been a good way to do it for me. A facilitated knowledge exchange, where I think we all understand. And here's this culture of learning. And I think that is super important. And as I do this longer and longer, you start to get into the nuances of it. I think that is more important than anything else that I'm talking about, is this culture of learning. And that's a real positive for people. It gives them they're comfortable asking questions, comfortable going out on a limb a little bit, and just more comfortable in general with you. And especially when you're doing a longitudinal clerkship for as long as the student's with you. It's quite amazing when that student is going to be there for many months. You may have a resident come and go. It's amazing how much more confident the student is. It's been there for 2 more months than the resident, about how the culture of learning, just confident to talk. And it's really very fun to watch. Okay, here's another one, integrating postgrad and undergrad general practice review. Same thing, we're going to go faster here. Vertical integration is what they called it, found helpful for students and residents. There's a few things that were different. The closer in age were thought to be key benefits for them. Again, I've been at this for a long time, and it just, the age thing is important. No one gets my Simpsons jokes anymore, which I find quite upsetting to me. All my references kind of just go right over their head. And so that's too bad, but that's my learning behavior. And this part of here, I think, is really important too. Suggested that if you happen to have 2 or 3 docs in a practice, it's important that students get exposed to them all. In Perth for our LIC, we always have 2 preceptors. We have since day one. We've never had a one-on-one preceptor model for the clerkship. We always have shared. So when we have Perth here, we have 3 students each time. We have 6 docs teaching those 3 students, which I think is important. You see different styles, and it's good for them to see different styles of medicine and realize that what they're learning from you isn't the right way, it's just your right way, and it's worked for you. And patient fatigue can become an issue, and that's something we can talk about a little bit later too. So what do the patients say after all this? So I'm just going to click on the chat. Okay. Literature review again. Here's the last one we talked about. So 3 core underpinning factors: successful multi-level learning. Again, I'm seeing the same thing over and over again. Again, strong teaching culture in the office. Again, is super important. Enjoyment of learning of the doc itself and the students is important. And the flexibility in the teaching delivery. So you don't have to be the same for every single person. You have multiple learners at the same time. The objectives are going to be a little bit different. Their learning styles are going to be different, and be flexible in the way you're teaching. And really, people care that you're nice, that you're caring, and that if you have that culture of caring and of caring about education in your office, all the other stuff kind of falls into place. Okay, so what I've done, I don't have them at all times. It's tiring. Okay, I'll be very honest with you. It does take a little bit longer. I saw that in the chat as well. Having 2 all the time it can be tiring. It's longer at the end of the day because you like to chat a little bit and whatnot. During the day, it's actually it's quite easy at times if you have a strong resident, but it does take time. So that part is there. And I like to have some time off of multiple learners at times. Every few months, at least, I take a break from that. I think it's super important, and this is a new part of my slide that I put in over the last little while. And again, reading a lot of evaluations at ERMEP as well. Going over the objectives separately is super important. That's what learners, number one thing that they think we can improve on as preceptors is day one, go over what your objectives are. It's not done a lot of times, and I didn't always make sure that I did it either. Super important. And I would definitely, in this situation, if layered learners, go over them separately. Take the resident aside if the student's around, or take the student aside, vice versa, and go over the objectives without the other learner there. And it's just nice to feel more comfortable what they want to learn, because they don't know the other person yet at that point to be comfortable with that. So that's what I would do. Again, I was really worried about the exposure. I don't have a huge practice, about 950 patients. Really not difficult at all, honestly, what it came down to. This is how I run it. I have 2 rooms. If anyone's been to my office, I was supposed to take some pictures and I didn't do it, but I have like no room. We're in a little corridor. I have 2 rooms. I'll double book usually my first appointment in the morning if there's patient demand. The student and the resident will each take a room, and I'll work with the student, usually leave the resident on their own until they have questions. When the residence has questions, I always involve the student in them. Again, I'm not double booking after that first appointment. So the rest of the day is actually quite smooth. If you want to hold back the student to hear some resident concerns and to go over things. And it makes for a nice flow, honestly. I usually don't have a room of my own. Very occasionally, I need to steal a room from one of my colleagues for something very quick, but it's not very often whatsoever. And an emerge, I do exactly the same thing. And if it's quieter in emerge, then you don't. But if it's busier in emerge, I stick with the student mostly, and my name's Virus, and the resident does their own thing. If it's slow, I get the student to present to the resident, and this one's a hard one for me. I have to sit there and bite my tongue. And if I'm needed, I'll help them out. But I think that's a great time. The residents love this time to act as a teacher themselves. And they don't seem to mind it. I've asked them lots if they mind me being there, listening to them talk to the student, and they don't mind that in my experience. Procedures, like we normally do. Residents have done it before. They're going to show the student or supervise the student. And if the resident hasn't done it, they get to do it with the student around, and then the student gets it next time. Patient feedback. So patient feedback is important in this situation because my patients see a lot of learners. Maybe they've chosen not to be with me over these last dozen years. They don't like students, but again, the learners or the patients I have quite seem to like it. Almost always positive. Some of them do get a little bit, sometimes say, hey, they may not see me once in a while. And usually if I have a resident see a patient, if I have a resident that has a relationship with a patient, then I just continue with that. If I have residents that are coming and going and the patient sees a couple residents, different residents in a row, I'll make sure I step in on one of those visits and just to make sure that I know what's going on a little bit, and it keeps everyone a little bit happier in that situation. I have a few, probably 5 of my 950 that only want to see me, and that's fine. They're kind of rude with the students, honestly, and I don't think it's a good experience for the students, and I'll usually tell the student why. Again, though, here's my disclaimer. I've always had a lot of students in my office. Most of my patients are very comfortable being seen by a learner, so they don't push back. And I think it's quite good. They honestly think it keeps, they get much better care, most of them, because they're up to date. Someone's talking about them lots. The cons. If the resident's brand new or struggling, it's hard. Okay, done. That's what it is. It can be much harder if the resident is struggling, because then you have to treat both as students, and then it's a lot of moving between rooms. It's much more difficult. Usually doesn't last for long, that situation, but it can be a con for sure. It's a con at the hospital too. Knowing who's who. It probably took 5 or 6 years to have it that the students had to have co-signed orders. Residents don't. I still get papers back today saying they won't accept orders because the resident signed it. So it's that kind of stuff. But honestly, Perth's been doing this for so long now, that's becoming easier and easier all the time. And you need to let go. You can't be OCD about this. You can't micromanage multiple learners at the same time. You have to trust them. These are adult learners, and you have to let them do some things. I always tell them I'm going to let them do a lot of things. I'm not going to let them hurt people. I'm not going to let them cause any harm in my mind. But you have to let go a little bit, because it's too hard otherwise, and it's too hard on your brain to try to micromanage multiple learners. The pros. Okay, so it makes a very social environment, and people know me, know that I like that part. Topics come up that you have no idea what's going to come up sometimes, and it keeps you sharper. And I'm looking up to date about things all the time that a student or resident mentions, and when they know a lot more about it than I do, I better learn up about it. Super pro, you need to do less documentation, which is great. I'm a terrible typer. Students are great nowadays, so EMR, they just rip it in there, and I have to go over it, which is nice. So I don't have to do a lot of typing myself, which is quite nice. And if you have a strong learner, it's very easy to double book patients very safely when you have the resident and the student there too. So I think that part is a pro. Here's a couple other pros I think is important, and Tony alluded to this a little bit in his talk too. I think it's important at this point that we expose undergraduate learners to colleagues that have chosen family medicine as their career. Our students get a lot of exposure to people who have not chosen family medicine as a career in their development. And this is really important. And it's been amazing to watch the students learn from the residents that have chosen this. And it gives them that mentor in there right off the bat. I think that's super important. And I think it will help promote students choosing community rural family medicine for the postgraduate training. And I haven't seen any studies on that. Maybe it's something we should do, but I can sure tell you by my N of 1 in our town of Perth, that's sure been the case. So multiple level, it can be fun, educational, help with workload, good for recruitment, can be tiring, but it's definitely clearly supported as well. And that's it. That's my talk. So please, questions, discussions. I'm looking at the chat here. Okay. I got some of the questions here. And yeah, Karen, you're right. In your grooming preceptors. Here, I won't share my screen anymore. Let's see if I can stop that. Perfect. I know I talked fast. I do apologize. Hopefully it wasn't too fast. Let's just go through some of the questions here. And you're grooming preceptors. Absolutely, we're grooming preceptors. The residents that teach these longitudinal clerkship, when they know them well, it's quite amazing. That's just what they do. They just become preceptors, most of them, which is quite fun. How long are appointments booked in my office? 15 minutes. So I do 15-minute appointments still. Sometimes there's 30s, but I don't. If I have a 30 with 2 learners, I'll book someone else during that 30 minutes. I'll do another 15 during that 30, if that makes sense. And scheduling office is supervised. So yes, I was going to ask the same thing. Advice on scheduling the office is supervising a medical student. I still, with a medical student, if I just have a medical student alone, I still do 15 minutes. The students will take sometimes shorter, a lot of times longer than that, and I'll work the other room. So I'll have, because my second room, I will see someone in the second room and still book every 15. Again, that's how I've been doing it. Tony, I see your hand.
Yeah, just a couple of points around what you were talking about. The first is on the teaching methodology, and I just wanted to share with you that what I've come to find is that in teaching the resident and the student at the same time around a case, like say one of them's seen a case and you've got the 2 of them together, I pitch the discussion at the resident, and I'll tell you why. These students are wicked smart in terms of picking up information and researching stuff. You don't have to worry about pushing them in terms of their knowledge. And by having the discussion with the resident around their aspects of the case, and then at the end saying to the student, okay, are there any questions or anything I can clarify or hit some points? You're raising the bar for the student without threatening them, without putting them on a spot with questions that are maybe over their head. And believe me, after a little while, you may not tell much difference in terms of who you're talking to. They will rise to the bar. And doing it that way, it does it in a way you're setting it, but not pushing them overtly or putting them in a position where they might feel threatened. The other point that Robin made that I just want to come back to is the role modeling that the resident provides. Some of us are a little older than the students now, and they relate really well to the residents. But I'll tell you too that there is a certain hidden curriculum. Well, there is a very real hidden curriculum among the students about who goes into family medicine and who doesn't. And when they see the folks who've chosen family medicine as a career and what they know and what they're like and what they do and how content they are, that speaks more to them about that career than anything we can tell them, any words we can tell them. So that environment of the student with the resident, it's supportive, it's nurturing, and I'll tell you, it sets a bar for the educational process that they rise to. Thanks.
Oh, those are all great points for sure, Tony. Thank you. Yeah, and it really is. It's nice to have role models for these guys because I'm not it anymore. So it is nice having someone that's closer to them. So thank you for that. Oh, we got lots of great questions here, guys. So I'll tell you, let's go through them here. So I'm just going to go through. Where are we here? Okay, so what have you done with students during COVID as a lot of visits have been virtual? We weren't, I did not do much virtual. We did COVID Teams back in April, May of 2020 in the inpatient work. So we did some virtual work. So we weren't allowed to be in hospital for 10 days after these COVID Teams. That was the beginning. We had no idea if we were all going to be sick or what was going on at that point. And then we had screening and I had people in my office. So again, there weren't students around right at the very beginning, but since everyone's come back, I've been not virtual. So I try to keep the students away from the virtual learning. I don't think phone calls for medical students are that helpful. The phone calls for some of the residents have been helpful. And if there's follow-up, I've been using the residents have been doing phone calls of follow-up appointments. If there's a bunch of virtuals and not now with telephones, I'll do most of the phones unless there's a relationship already between the learners and have them see somebody in person. So that's what I've done that way. How do you shift from one learner to another, given their different objectives? Yeah, that's hard. And I think I like the way that Tony put that. I don't know if I must shift, honestly. I usually I forward my questions to the resident if they're there first. If the resident's not there, I've taught students long enough that that's just my default is talking to students about to try to push them, however they're presenting, try to push them a little bit further. The resident, I'm pushing more for plans. What happens if something comes back, tests come back normal, those kind of things. The hardest questions you can ask a learner is what happens when everything's normal. Anyways, medical students, not quite the same. I don't have a great answer for that. It's just, I don't know. I think I've been doing it for long enough that I just kind of follow their and try to read them. That's a good question for different objectives. So I don't know the answer. That's something I'm going to take home, but I haven't found it to be difficult. At least they haven't told me I'm bad at it. Do you send results to students, residents, to discussion manage? Absolutely. So residents I leave their stuff for them to see their results. I review them really quickly when I get them in my inbox in the EMR. But if a resident ordered the test, they see the result and they have to decide what they're doing with said result. The students, I usually deal with the result myself, but make sure the student knows what it is. So you do have to have some sort of idea which your patients had seen a learner. So you do have to keep that a little bit in mind for follow-up results. And I'm not perfect. There's sometimes I miss stuff and the student asks, hey, what happened with that test I ordered? And I go, right, well, this happened. And I tell them later on. So I'm definitely not perfect at that at all. But I try to remember and try to have the resident definitely go over it and the students go over the results with the students of tests that they have ordered. I've not had learners with me in office before. Wondering if any advice for increasing patient acceptance. Yeah, okay. I'm flashing back on this one too, that's for sure. We do have some signage. We have signs that we have students in the office out front. When I first started, I had my reception staff say there is a learner with people today. So they weren't surprised when someone different came to the door to call them in. So I did do that at first. I don't do that anymore because now it's just what it is, but I did do that at first for sure. And I have the students have a little spiel that at the beginning and that the medical student, they're going to talk to said person first and then go over and then I will see them after. And they say that even in the walk into the room, just takes off and people don't usually push back on that, that part that they're going to see the doctor as well. Residents don't do it anymore. They just say they're the resident and my patients don't push back on that part because they quite like having the learners. But I think saying that they're going to see them first and that they're going to present what the case is to the doctor, that goes over really well. Some people aren't going to like it and they're just going to have with that, and that's fine. That's just what it is too. So, but that's why I have the students tell them at first. I'll go through more questions after Tony. I see your hand up again. Was that an old hand, Tony, or?
I was just going to add to that. When we've actually looked into this, what patient acceptance of students, and Robin's quite right. What they fear, most of them, is not seeing the students, that they're not going to see you. We just need to reassure them that the student is not a substitute for seeing the doctor. And that thing that, they're going to see you first and then we're going to see you together. They actually like that because they know they're going to get gone over. Now, there are a few who just don't. And there are people out there who, for some reason or other, just are completely averse to seeing a learner. And we would never suggest that you push those people away. I mean, that's not the object here. But they are few, and most, once they're reassured that this is not either or, are quite accepting.
Great, thanks for sure. And I see some more here. They love students. Yep, most of my patients absolutely love students, and some of them, like I had one of my community residents that I had a baby, and the amount of presents that came from people making things for the baby and whatnot, dropping off at my office was absolutely amazing. And and that resident wasn't even with me anymore at that time. Like it's so amazing. So it's very, very sweet. I've had a Queen's integrated student, just for, if we're talking stories here, literally saved the life of one of my patients. We all know how transfers of care go. We had a patient in Perth that was very sick, ended up being hepatic encephalopathy, and was in Kingston, and basically was a GCS of 4 in Kingston at KGH, and they saw the person at KGH. Everyone at KGH thought this was kind of the normal. This was baseline for the patient, and the student was able to advocate for them that it wasn't baseline. Got neurology involved, and this man is alive today, totally fine afterwards. And it could have been one of those guys just lost in translation, coming down for MRIs, and it was really amazing. So that was right at the very beginning of one of the integrated. It was absolutely very, very cool. So, and that family does not mind students, that's for sure. I'll tell you that right now, that's for sure. Let's see what so again, patients really do like the learners, and I think the learners here are good. These are smart students we're talking about. They're pleasant, they're nice, they know how to talk. Well, most of them know how to talk to people. So let's put it that way. And then for longitudinal students, is there self-selection bias, interest in family medicine? Yes. That's a good question. Shane will probably know this better than I. So out of my residents or the students I've had over the year, the majority would be family medicine, would have matched to family medicine. A few of them, I guarantee you, were changed from coming to us, because everyone wants something else when they come out in third year clerkship. They don't want family because they have no exposure to family medicine. But I've had radiology, internal medicine, psychiatry, we've had orthopedic surgery, had a bunch of others come to us. When integrated first started for us, some of our stuff was post-CARMS match at the very beginning, so they weren't as interested in family medicine, but now it's all pre-CARMS, so students are interested in getting these things done early to get their exposures pre-CARMS. So most of them there is some interest in family, but not all. I've had a bunch going to emerge and whatnot otherwise, but honestly, I think it's great for the person who's a subspecialist. I want to call the neurosurgeon who knows what I have to deal with in Perth on a regular basis. And because I work in Napanee or Perth or Collingwood for 4 months to a year, I want to know what you're dealing with in resources. That's who I want talking to me on the phone. So I think that's important. Go ahead, Tony.
Well, that's what we try to tell them, right? And honestly, I think these are almost more valuable for the students who don't think or don't end up in family medicine. And what we try to tell them is that this is not about early starting your family medicine career. This is about, for those who are going to do subspecialties, teaching you consultancy and giving you a sense of the physician role that you won't otherwise get. You're going to spend your whole career learning to be a plastic surgeon or interventional cardiologist or whatever. This is time when you can learn about the relevance of what you do to patients and to referring physicians, and what primary presentations look like. And most of them buy into that. Now, there are a few who are just focused on whatever it is they want to do, and are less engaged. And honestly, those folks we need to have a talk with. So if you're identifying students who don't appear to be motivated or any issues at all, we want to be involved in that. So if you're having issues of any type, those are things we want to talk about along the way, not after the rotation's over. So there's a dialogue that occurs, and and Shayna's really tuned into these. If we're having issues with students in any way, we want to be part of that early on and deal with it early on.
Perfect. Personally, I've not had exposure to someone who doesn't want to be here for integrated. It's quite popular, and when I talk to Shayna and when the students are putting their ranking list for rotations, the integrated programs are quite popular. So here's a good question for
just another anecdote. The very first student we ever placed, the biggest problem we had was that this young woman had never lived outside of downtown Toronto, and found herself in Perth. And there wasn't an issue around the medical environment. It was the environment, she just didn't know how to function in a smaller place. But once we got over that, all was fine.
I remember that well, actually. That was fun. Yeah.
You remember the hair salon problem, right?
Yeah.
And the flip side of that is, I know, Robin, you've had prior to COVID, the student who was coaching 2 basketball teams while being there. We have a course director for another discipline who, as an LIC student in Brockville, was teaching yoga at the Y, and it's just, the experience is so rich. And yesterday, the soon to be graduating class were talking about their clerkship experiences with the newest ones who will be starting in the fall. And Chris and I were talking to each other, just our hearts were so full hearing them talk about their experiences that they had on the LICs and the way that they were welcomed and really came into themselves as physicians wherever they're heading.
Great, thanks. Here's a good question, I think, here too. So Andrew had given us a good question. If a student and resident are seeing patients at the same time and the office is busy, they might miss each other. And then they both review with me. They work in a silo. Absolutely, it happens. Okay, this is a normal thing that happens, especially in Emerge. Emerge, it happens all the time. Yes, they work in silos. What I do, if there's something interesting in that situation, I'll bring it up to the other learner. Something's going on. If there's not, I let it go silo. I'm not seeing the patients myself. I don't have to document a thing in these situations. So my time isn't that bad. I just switch from one to the other and go over patient care. And honestly, you're probably treating them both as residents at that point when it's busy like that. And as Tony said, these students are bright. They don't mind being treated as a resident. They don't mind being challenged. If there's not someone right in front of them that they have to flounder around, if it's just you have a relationship, you've worked with them for a while, if they don't know, they're going to tell you, I don't know. And then they're going to go from that. But it does happen lots as a silo for sure. I don't know if it's more of the time or less, but in busy Emerge time in the summer in Perth, it's silo. That's just what it is. So, I try not to avoid it. There's nothing you can do. I still feel, and I still promote to my students that I'm not a teaching hospital. So I'm going to let's take Emerge, for example, where this happens. I'm not a teaching hospital. That is a community hospital. I care about length of stay times. I care about the chart buildup of patients that need to be seen. And I promote that to our learners as well. And I hope they take that home, that patients waiting there's problems that can happen with patients waiting. And we need to keep the office or the Emerge moving. And that to me is a huge part of it too. And I teach that to my learners as well.
Just as I'm being mindful of the time, I was going to maybe just say.
I'm sorry. I thought it was going to be short. No, sorry, but the questions have been great. Yeah.
No, we're right on time, and I wanted to say thank you so much for the talk and leading the discussion, and for everyone engaging in the chat. I think this has been really, really wonderful. So thank you so much, Dr. Kenny, and really appreciate your time and presentation. Next step, I think we will pass it over to Dr. Mike Ward to speak to continue some of this thread with respect to learner-centered teaching. And then following the next presentation, we'll have a short break. And Dr. Ward, let me know if you would like us to share the screen or if you would like to.
I unmute myself. I can do that, Natalie, if you can make me capable of that.
I think you should still be a co-host, but let me know if that's not the case. If you can see the green share screen button at the bottom.
Yeah, beautiful. Thank you.
Perfect.
It looks like that's going to work. Thank you.
Okay.
Slideshow from the beginning. Can everybody see my slides okay? Just a quick thumbs up, maybe. Thank you very much, Shayna. So thanks everybody for coming today. There's a lot of docs present and learners and everyone else. So that's awesome. Congratulations to the organizers. My time today is to provide some teaching in ambulatory care. And really, we're going to look at some tips and tools that you might want to take advantage of at some point during your learning career. Disclosure, I'm a community family doc. I work in the Bowmanville Family Medicine Residency Program, so-called QBAL, and the new LIC. I have no commercial interests. And now that I've seen Robin's talk, I realize I do have a bit of conflict of interest potentially. I am also involved in some ways in the administration of both of these programs, but I'll try to keep that off to the side. Objectives for the next few minutes. I'd like to give you really just some ideas about the big picture of the learning episode and the teaching role that you're going to take on. I'd like to give you some ideas and snapshots into some teaching tools that are learner-centered. And probably many of you have heard of the 1-minute preceptor model. We'll talk about that in some detail. I'm going to introduce you to the SNAPS mnemonic, another slightly more advanced teaching tool that you may choose to make use of. We'll explore the TIPS acronym, which is a really cool way to help develop differential diagnoses in your learners. And then, like Robin, I'm just going to delve into the literature at the end a little tiny bit and provide what I hope are going to be some practical tips for you that are derived specifically from the LIC literature. So as we step back and think about the big picture, we have priorities when we take on the role of educator. And I think the priorities involve everybody that's playing the game. Certainly directed towards our learners' safety, their growth and development, and identities as professionals as we role model and teach and move through the system with them. And in the LIC, that takes on significant meaning because the students are with you for a good amount of time. Our patients are likewise central in it, and their ongoing health is often reflective of the educational opportunities and experiences that your residents and students will have with them. And like Robin said, many of my patients, now I'm semi-retired now, so I don't have a family practice per se anymore. I do most of my teaching in outpatient clinics now, but like Robin had echoed before, many of the patients are absolutely ecstatic to see your learners, whether they're LIC students or, like Robin says, hopefully you'll be able to layer your learning with residents at the same time at some point. And although the literature has not been as robust in recognizing the importance and resilience of the preceptor, Shayna and Tony have both echoed how important resilience and CME and development and satisfaction, how important that is to the success of your learning when programs recognize how valuable the preceptor is in this entire equation. There we go. So from an educational model or something, I'm sure that everyone who's got involved in teaching so far is well connected to these concepts, but I just wanted to review them briefly for you before we talked about learner-centered education per se, because I think many of these ideas form a central platform that helps to launch your career and will allow you to build upon your actions as teachers as you move forward. So the educational alliance, or the learning culture, as Robin alluded to, is absolutely central to your success as a teacher. It helps you build relationships with your learners. And like Robin and many of you in the audience right now, it will be very cool over time with iterations of students that move back and forth from your community and your office to just sit back and think about the old days and the relationships that you had, your residents that have children, your LICs that have children, etc. That same thing has happened in my office, and it is a very cool experience. You will be the role model for your learners, and it's really like you're an actor or an actress on stage, to be quite honest. Your learners will see and hear everything that you do. And so it's important to recognize that you're modeling in front of your students, because your actions will often speak louder than your words. Feedback, we're going to hear We're going to hear a little bit later from Dr. Euler about the value of feedback and really the importance of it as a foundational learning concept. And there are tricks to the trade that I think we're going to hear a little bit more about as we move on. And in fact, the ability to deliver constructive, positive, corrective feedback is one of the elemental portions of the 1 minute preceptor and the SNAPS mnemonic that we'll talk about a little bit later on. As a mentor, you will provide career advice for your learners, whether they be with you for shorter or longer times. It will be part of how you develop yourself as a teacher. It's important when we talk about what characteristics do learners find valuable in their teachers. The idea of scholarship has become a very important component of our ability to pass on information to our learners, whether it's through frank research. At the Bowmanville program, one of our first LIC students presented at the CLIC that Shana was talking about, that the Consortium of Longitudinal Integrated Clerkships. There was a presentation in Vancouver, and one of my partners did the same for a project that we had worked on. So with the idea of scholarship coming into the curriculum in Queens this year for undergraduates, that will become an important part of your role as teacher as well. And then the concept of reflecting as a physician, as a teacher, as an educator, as a person. It is valuable exercise, I think, in the world of mindfulness that we think about often these days, to take some time when you have it, whether it's a warm bath at the end of the day, a glass of wine on a Friday afternoon, whatever it is, just to reflect on what you've done the last few weeks or few months. How can you improve? What worked good? Like Robin said, what mistakes have I made? How can I improve my teaching experience for my students as we move forward? So laying that platform down for you and those elemental concepts of successful teaching, which by and large are mostly commonsensical, but sometimes it's important just to see them laid out for us as a footprint to start. Let's think about the 1 minute preceptor. This thing is 30 years old. Dr. Nair published this 1992, I believe it was close to the end of the year, so maybe not quite 30 years, but it's coming on its 30-year anniversary. It was originally designed to teach family medicine residents back in the day. And it is the most studied of all teaching tools that are used in the academic world. It's been shown in multiple different studies to increase information uptake, to develop and augment your teaching skills as teacher and preceptor. The model came from pharmacy literature, as it turns out, even some 15 years prior to when Dr. Nair's group first published it. So it's set in old school learning concepts that have by and large proved to show the test of time. The original model contained what are called 5 micro skills, but they're very straightforward in their mechanics. And this is the guts of the 1 minute preceptor, essentially the steps that you may find yourself moving through in more early parts of your teaching career with learners. And really, the nuts and bolts of it go like this. It asks you to listen to history and physical presented by your student, and then to stop. And like Robin said, don't jump in to take everything over. Step back. This is learner-centered, remember. Ask your learner to commit to a diagnosis or a plan. Then we probe them for supporting evidence to try to understand what the thought process is they're going through to get to that commitment. Offer feedback about what they did well. Offer feedback about what they might want to pursue a little bit later on and understand in more detail. Take the opportunity next to teach some kind of general principle related to the presenting case. And then the very newest portion of OMP that's been added is plan for the next steps, bringing by and large a natural conclusion and modeling what we do every day when we hear history and physical and make a plan. So I'd like to take the next couple of minutes to delve into the individual steps of the 1 minute preceptor. And we're going to use as a model a case of a sore throat presentation in your emerge or your outpatient clinic or your family practice office. Remember that this is a learner-centered model that is driven by a patient preceptor. It is very important not to jump in and take over the case. Remember that by jumping in and taking over, all you're teaching the learner is how you think. By stepping back and listening actively to your student, you will start to learn how they think and then help them augment or modify as needed. Although the model is presented in 6 steps, you don't necessarily use all steps at every encounter. And although there's a process to the steps, they can be carried out in any order. And as you become more familiar with how this model is delivered over time, you will pick and choose what you think is most appropriate for that particular encounter. So let's look at how it works logistically. So this is an example of history and physical that would be presented to you by your learner. So a little 12-year-old lady with sore throat for a couple days, had a fever yesterday. There was no coughing, no rashes, no chest pain, shortness of breath. The patient is tired. She has some minor past medical history and allergies. She looks well, which is nice to hear from your student. She is afebrile with a red throat, and the rest of her examination is unremarkable. Now, I know the family practice people in you are dying to ask some more questions and fill this history out a little bit further, but this is where you stop and step back as the teacher. Get a commitment. Focus on a learning point, right? Encourage thinking and reasoning skill development in your student and engage them. And like Robin said, be prepared to push them a little bit past their comfort zone when you ask them questions or plan to ask questions in this episode. And it can be a very simple statement to start. So tell me what you think is going on with this patient. Bang, step 1 is done. Your learner answers back, viral pharyngitis, but it could be strep throat, and I don't really know. And that's okay, because that's a great answer. Next step in the models, probe for supporting evidence, uncover the basis for what the student is committing to. Was it luck? Was it a guess? Or was it based on previous foundational knowledge that you perhaps need to build on? This is the so-called intuitive look at the learner's mind map, or how they create their decision trees over time. And again, something very simple from you, nothing complicated. What other factors in the history and physical support your diagnosis, your probing for their thought processes? And this would be a typical answer. The patient's not coughing, does not have a fever, but the patient's mother says this is always what happens when she gets strep throat. I've probably heard that 1,000 or more times, and I'm sure you have too. And importantly, she doesn't look sick. Nice to hear. What do you do now? Third step, you step back and provide appropriate feedback for what was done well. Feedback, like we're going to hear from Karen, is foundational in terms of reinforcing behavior and knowledge accumulation. It is best delivered timely from a trusted preceptor and constructively. So you're trying to build their confidence and help them understand what they have done well. And something simple, again, strategic. It sounds like you correctly recognize the importance of lack of cough and lack of fever in the differential diagnosis of strep. Fantastic. Next step, constructive feedback about what might have been missed. We've all heard the famous quote, "I don't know what I don't know." In early learners and learners at different stages in their development, this is critically clear. Many times for me, I have to tell the students now, you know what, I just don't know what I don't know. We better read up on that or look at what the current guideline is or whatever it may be. But again, as we'll hear later, respectfully delivered corrective feedback is foundational, because without it, it will be difficult for your learner to make positive change and stop making or repeating mistakes that may be harmful for them as time goes on. And something like, it would be helpful to know if the patient had tonsillar exudate or palpable nodes in your examination. That's the part of the construction, because the important part is these 2 clinical signs can help you further narrow your differential diagnosis towards or away from group A strep. Again, you're providing a link for them to what they've done well and what they need to consider as they move forward when they see this same case again. Teach a general principle. This is where the preceptor shines. So share a pearl of your wisdom or your experiences to help them build upon wisdom and experiences of their own. These are guiding principles that the students will use in the sort of big picture as they move farther and see more patients. So something like deciding on a clinical diagnosis of bacterial or viral pharyngitis can be challenging. And quite frankly, it can be. Fortunately, the McIsaac score is a useful tool and can be found detailed in the Ontario Anti-Infective Guidelines. We all have these books or these pocket references in our clinics that we can use and make available to the students. Last is to plan for the next steps, the natural conclusion to the patient interaction. Summarize and conclude with a plan. This may relate to management or follow-up or guideline review or reading assignment or whatever. And for this assessment, it would be, let me show you how to do a rapid strep test, and then we can move on from there. So in its entirety, the 1 minute preceptor takes about 5 minutes, to be honest. It can be 5 or 8 minutes, give or take. It's certainly not 1 minute, so don't let the name misguide you in that regard. It's still a full teaching encounter, but it can be pretty logistically worked through and create this repeatable environment for you to build your confidence as your teacher. So let's see how quickly it actually can proceed when you're in the clinic and working from ground up. So your learner presents their history and physical, the commitment. What do you think is going on with this patient? Viral pharyngitis, but it might be strep throat. Probing. What parts of the history and physical can help you decide? Well, the patient's not coughing, doesn't have a fever. She doesn't really look sick, but mom says this is what always happens when she gets strep throat. Well, you know what? It looks like you realize the importance of lack of cough and fever in the differential. The assessments, all assessments of sore throat should document this. And in addition, it'd be good to know if your patient had tonsillar exudate or palpable nose, because this can help in your differential diagnosis. Let's look at the McIsaac score, and I'll teach you how to use that, and we'll see if it can make things any easier for us. And if she meets the certain criteria on the score, we'll do a rapid strep test, and then we'll decide what to do from there. That can be as quick and easy as you need it to be, given this relatively simple presentation. I very well understand presentations often are far more complicated and will require more input and more time on your part. But just to show you how the algorithm works, I've chosen this example. Success of the 1 minute preceptor requires you to be patient. You really do need, like Robin said, to refrain from jumping into the case and taking over. Remember that this is learner-centered, not preceptor-centered. So it's not that you need to teach the students the way you think. You need to understand the way your learner thinks and then help modify that as required. So it is a so-called learner-centered, preceptor-driven machine. It's a great tool for teachers who are new and for early learners in particular, where foundational knowledge perhaps is not quite fully developed. And again, it gives you a reliable, repeatable teaching technique as you work through more students and gain more experience. So I'm happy to entertain some questions about the 1 minute preceptor, and I wonder if we should probably do that at the end. I did want to introduce for you the concept of the SNAPS algorithm. It's not likely that you would use SNAPS right off the bat, but I have to tell you, when you're in a longer LIC, like in Bowmanville, we have our students for almost the entirety of their training, which has been rather remarkable. And seeing the growth in the students is really tremendous over the time. By about 4 months, many of my clerks are very clearly working at the level of the first-year family medicine resident, and I have no concerns about that at all. And I will often switch gears and mix and match treatment strategy or teaching strategies based on that idea. So in contrast to the 1 minute preceptor, in the SNAPS algorithm, the preceptor really takes the role of facilitator. If you look back at all the italicized writing I had on the slides, that's all the vocal part of the preceptor in the 1 minute preceptor model. The preceptor does the bulk of the talking in that, and therefore translates the bulk of information. But SNAPS requires a learner to be able to do the bulk of the translation. It is, from a cognitive perspective, strongly important in promoting critical and thinking and reasoning. And it likewise helps to develop these so-called treatment trees or mind maps that your students will develop over the time. And in the SNAPS model, the preceptor serves as a knowledge source rather than a knowledge presenter, as they are doing in the 1 minute preceptor. It is a learner-centered, learner-driven tool, and it's a great tool to learn. And I'm going to introduce it to you in a second. This is a wonderful tool because the learner takes on an active role in the educational encounter. And it does require a slightly more advanced learner, but it doesn't take long for many of your LICs to get there. You discuss the patient encounter beyond the facts, and it's helpful in having students verbalize their clinical reasoning. And you really learn a lot about how they're thinking when you use the SNAPS algorithm. Like I said, though, as an introduction, SNAPS typically is something that you will introduce later in your teaching volley with your students, because it typically requires a more advanced learner. And it also requires a comfortable preceptor. There's a little bit more training that's involved in this algorithm. It's not as simple and straightforward as the 1 minute preceptor. And this is essentially what the SNAPS is made of. You summarize, or your student comes to you and summarizes the history and physical findings. They verbalize to you and narrow the differential diagnosis to 2 or 3 things that are relevant. They analyze in front of you the differential, comparing and contrasting possibilities, and they ask you questions. You kind of sit back with your hands at your side, listening, understanding what they're saying, trying to figure out where they're going. And then they ask you questions about differentials, about extra things on history and physical, about plan, and so on. And then they select something that is going to be useful for self-directed learning with your help. So again, you act more as the facilitator in this learning encounter than you would in the 1 minute preceptor model. Comparing and contrasting, it's really essentially just what I have written or discussed for you. The 1 minute preceptor is driven by you as the teacher, but it is learner centered. It is great for new faculty, for early learners, and its repeatability is wonderful because it helps you maintain a constant level of thought as you're going through. It is great for encouraging clinical reasoning, relies strongly on feedback and good clinical relationships with your learners. So those are the 2 best studied teaching algorithms out there on the market. I think 1 minute preceptor is 3 decades, and the SNAPS is coming up to its 2nd decade. The TIPS mnemonic is actually difficult to find detailed in the literature. But it's very commonly used by teachers to help learners develop differential diagnoses, skill set development. And it's typically an iterative kind of tool, often used in outpatient settings and in the emerge especially. It helps learners to create or identify non-classic patterns and presentations of illnesses. And what it is if we relate it to our pharyngitis case, it's a very straightforward working algorithm. So T is treatable. What can we fix? And in our case, it would be group A strep, for example. I stands for interesting. So what I like to call colloquially a U of T diagnosis. So Lemierre's disease, for example, if anybody still remembers that. P is probable. Common things are common. So rhinovirus is probably one of the most common causes of pharyngitis. And then serious, the must not miss stuff. And again, the emerge docs will be well versed with this in the audience. So for example, something like adult onset epiglottitis when we're talking about pharyngitis. And just as an aside, it was really fun. I had a resident and student with me just a couple months ago in our urgent care. We've opened our urgent care up now to see all comers, which is kind of refreshing after COVID. But But my resident had seen a patient with a very interesting story for pharyngitis. And so we sat down, like Robin had talked about, with resident and student and just went through the case tidbit by tidbit after it was presented. And one of the significant differential diagnosis was actually adult onset epiglottitis. And neither the resident nor the clerk had ever had entertained the idea that adults could get epiglottitis. Because again, in our teaching, we're so foundational about Hib vaccine that we've essentially announced that we've eliminated epiglottitis from the world's repertoire in Canada. So to be able to offer them both at the same time, the idea of epiglottitis in adults was very cool. You could see literally the lights turn on in their minds as they started to learn how to develop more differential diagnosis. It was a very exciting day, actually. And of course, the patient didn't have that. We did a rapid strep and they had strep, but it was still very exciting to see that learning opportunity. So that's my gig about teaching tools that are out there in the world, the 1-minute preceptor snaps and the tips algorithm. I would like to take the bit of time that I've got left and give you a little bit of pearls from the literature. As you can imagine, the very first LIC, when you look historically, was at Harvard, I think in 2004, give or take, an LIC program. And then since then, as Tony and Shana have said, LICs have just blossomed. They're outstanding clinical teaching models, and they're being used all over the world. There is a delvature of literature out there now looking at LICs, but there are 2 real cool papers that were published in the last few years that I thought I would just bring to your attention, so you would have them and perhaps gain a little bit of tip from what they talk about. In this first paper by Robin Latessa from the Chapel Hill group, what they did was they introduced the LIC in 2008 in North Carolina, and they had 4 years worth of students run through their LIC, and for 27 students in total. And what they did was they had a research associate do semi-structured interviews to each and every one of those students after they had passed through the LIC. And they accumulated all that data and created 7 kind of themes out of the data that they had captured, and brought out of that 7 themes 9 tips for preceptor teaching in longitudinal integrated clerkships. And the box 1 is on the side for you, and I'll let you go through that on your own. I just wanted to highlight a few of what I thought were very important, again, important things for us to think about as teachers. And one of the ideas was bringbacks, or bringbacks are basically defined as small bits of teaching, whether they could be assignments, whether they could be guideline reviews, etc. But introducing small teachable evidence-based things in your clinic, but being sure that they were reviewed after the students had an opportunity to look at them a little bit more closely and bring them back, whether it was the next day or the day before. So the idea of assigning, but then making sure that you follow up and review that for the teaching. Having the clerks appreciated having their teachers observe them one-on-one in the clinic, especially when related to physical examinations, to make sure that they were progressing appropriately. The clerk said, and I quote, "You can never ask too many questions." So they loved the idea that preceptors would probe them with questions related to the clinical cases that they were involved in. They needed very much constructive feedback on things that they were doing right, and much more importantly, things that perhaps they needed guidance on and didn't feel comfortable with. And they also appreciated from their teachers the concept of producing and providing a sense of ownership for them with their patients and with the clinical story. They felt that empowering ownership within the students helped them develop their physician identities. And then there are several other things in box 1 that you might want to have a peek at some point, but those are the big pearls from that particular study. This group, together with David Hirsch from Harvard, went on to do a literature review a few years later and published in 2019. They did a literature review and stepped back with a bunch of the information they had found from LICs being described in literature to create what they call the 7 Cs. And the 7 C's, they feel, again, are foundational concepts for teachers to understand and pursue in teaching excellence in the setting of an LIC. Continuity, so supporting and engaging continuity with patients, with students with the community, and with students with the strategies for teaching going around them, including their hospital times. Building connections between students and patients in addition to continuity, and connections that the students were able to become more appropriately involved in. Communication strategies with students and especially staff, so that students were aware should there be any changes, staff become familiar with students, it enhances booking and so on. Having their teachers act as coaches, guides, and mentors, and having their teachers expectations of high standing from the students. So they wanted to make sure that the teachers expected that they would perform well. They need commitment, advancing students' roles and their responsibilities and their growth as they move longer through their LIC to create more autonomy and again, develop their identification as physicians. They needed to see humanistic modeling of empathy and appropriate clinical care provided by their teachers. And they wanted opportunities to engage in their community, whether it be with hospital, through community outreach, or through research even. And this has been brought through the literature. Box 2 from this same group again provides a bunch more practical tips for ambulatory teachers. And again, the big ones are shadowed on the right for you, orientating your learning and orientating your learner and discussing their learning plan at the beginning of the LIC. What are their goals and how can you help them? Scheduling. So like Robin said, think about if you have 1 or 2 learners or even 1 learner with limited space, how you would schedule for success. They use the term wave scheduling to, for some reason, to describe what Robin said, essentially double booking patients at strategic times in the hour, so that perhaps the student can have a half an hour with a patient, you can have 15 minutes with the first patient, and then you'll still leave yourself time to review with your students. Role modeling, we've talked about its importance, developing autonomy for your students as you move through or as they move through their educational experience, foundations of feedback, and again, community engagement as time goes on. And the last paper, just for fun, I thought this was really neat. It was published just towards the end of 2021. This is actually insight from 3 LIC students that were involved in the University of London's program. And they have a super cool program. There are 270 learners in this program, and a full 1/3 of them, I don't know how they did this, to be honest, but a full 1/3 of them are sent out into the community for an LIC, 90 students. Shana, that's a lot of people. But anyways, so they've had tons of feedback from their students over time. And I thought this was really neat because for those of you who are going to host LIC students, this is a really neat pictorial for what the students suggest students should do when they're preparing for an LIC experience. And this is from colleague to colleague, as Tony would say. So the students suggest that other students be organized. Preparation is the key to success in an LIC. Take initiative, be proactive for your learning needs in maintaining continuity with your patients and your teachers. Be proactive. Remember that you're working together as a student. Be open and curious. Play your part, they say. You learn from every single patient. And I tell my students all the time, I don't want you to do a history and physical in 5 or 10 minutes. These patients are rich with learning opportunities. Please don't rush your experience. I don't need you to rush. I'll see the patients that I gotta see. We only see 4 people an hour. We're not a fast flow through kind of place. Take the time, ask questions, learn. The patients will give you tons of information. As a student, Ask for help. Remember, you're not alone. When you don't know what's going on, ask your preceptor, or if you're in a layered learner situation, ask one of the residents who you're working with. Challenge yourself, the concept of the 1 minute preceptor. Push yourself past your comfort zone. You will learn more and feedback will be richer for it. And then, like we talked about in the big picture, the opportunity for students to take some time and reflect on what they've learned and what their processes have been like, how they can improve it for themselves as time goes on to improve their overall educational experience. And when learners leave your program, if these are some of the feedback quotes you get, you will have been extraordinarily successful. I had access to incredible teaching moments that may not have been reproducible in a traditional block curriculum. I saw the journey of a patient through primary and secondary care, increasing my understanding of their overall illness experience. I fostered a natural and long-lasting relationship with my patient built on trust and respect. Absolutely extraordinary outcome for individual students from an LIC experience. So I don't want, there's tons and tons of literature. I'm a big literature guy. I like that. I like research. I like literature, maybe a little bit too much. I don't want to bother you with too much, but a few take home points. Remember the big picture as a teacher, your relationships, your role modeling, your acting by and large, your feedback, your mentorship, opportunities for scholarship and reflection. The 1 minute preceptor is a great teaching tool. I would advocate its use and encourage you to learn a little bit more about it. Snaps certainly learn about at some point because it is a great process to drive learning in your more mature learners. The TIPS is a great acronym or a great model for broadening differential diagnosis. And then again, at the end of the day, take your time to reflect. You're a teacher, you're a physician, you're human, many different aspects, many complicated roles you'll take on as a teacher. Just take some time and have some fun. And I have to tell you, I'm very happy now that my academic portion of this is over. I got to tell you a short little story. So I believe it was Phil Watman, who was the dean at the time before Rosica, came to us in Bowmanville and introduced the concept of an LIC in Bowmanville. And we were already a long-standing teaching site for family medicine residents for Queens and U of T at the time. And so, of course, we were just totally over the moon about this idea about hosting a regular LIC program in Bowmanville. And so they said, we got to take you to this guy who's going to teach you a lot about LIC teaching. And I was like, oh my God, that sounds like pressure-filled and dramatic. I'm a little stressed now. So I said, okay. He said, you have to go to Perth. I said, okay. So what do? We go and meet Robin for the very first time. And I'm like a little stressed. I got to tell you, I'm like, oh man, what am I getting myself into here? And we walk into the room and Robin's with another lad. And I apologize. It's been a few years. I can't remember the other gentleman's name. But Robin said to me, there's no need to stress. This is just a lot of fun. Just go out there and have some fun with the learners. You'll have a blast. And so that is going to be my best advice to all of you as you move through and start your LIC in Napanee and wherever else you're doing LICs. Robin is 100% correct. You know, I am always about evidence and literature and yada, yada, yada. And my students and friends will tell you the same. But at the end of the day, teaching is about having fun. It's about making connections. It's about helping your students and helping your patients. And I congratulate all of you on either starting or continuing your careers as teacher, because I think it's an awesome way to give back to the system and to your community as a whole. You will be very happy and very satisfied when you start your LIC journey. Having that said, I'm done. I'm happy to entertain any questions that you may have. And if I can't answer them, there's lots of people in the audience who can.
Thank you so much, Mike, for that talk. And I'll say we probably have time for 1 or 2 questions, and then we'll take a moment for a short break, if that's all right with everyone. So if there is a question, I think there's one from Shayna in the chat to Jeff, perhaps, but Shayna, would you like me to read that out loud?
Not necessary. It's okay if Jeff wants to answer or if there's other questions.
Yeah. Yeah, I'm happy to speak to that, Shana, if you'd like. And I also thank other people who've taught me over the years about how to do that effectively. And one of the key things is to make sure that the patient in the room is directed to the student or the learner, and you sit off in a corner away out of the view of the patient while you're doing your observation, so that they don't engage with you, because their natural tendency is to connect with you as their family physician. And if they look at you, look away from them and look at the student or the learner, so that they're actually doing the engaging with the patient. And occasionally you have to step out with the student if there's something going really haywire in the interaction. But most of the time you can just sit there, take notes, and then leave when you feel like you've done enough observation, and usually it's just during the history or the physical or a piece of the interview. So it's a very powerful tool. Students sometimes don't like you being there, but it is very revealing in some instances.
Thank you so much. And is there any other questions, or maybe one more question? Yeah, for Mike in the chat, Laura, so would you be able to shoot us the last 3 references, share it with the group? So yes, we can pass that through our channels when we follow up with everyone, perhaps with the recording, and share that.
Yep, happy to get that done.
Okay, wonderful. All right, thank you so much. Thank you to Shana, Robin, and Mike, who presented thus far. And now I'd like to take a moment. We'll take a short break. I'm really excited to introduce Dr. Karen Euler next, who's going to be speaking about difficult conversations and constructive feedback, and how to work with learners in the clinical environment with those 2 things in mind, who's joining us from the Clarksburg Medical Group up in Collingwood. So thank you so much, and I will pass it over to you.
Thank you. Thanks for having me. This is the first time I've given this talk, so I put my email so that you can give me constructive feedback about my presentation, because I'm happy to improve it and make it better, and hopefully I can present it again. So my disclosures are, I'm going to be recommending the Crucial Conversations course. I took this course maybe 5 years ago, and probably a lot of you have taken it as well. It's, I think, a 3-day course. Our hospital paid for it. It's an expensive course, but a great course. And I took away some really good tools from that. And of course, I'm getting paid for this talk. So those are my disclosures. My outline for the talk is I'm going to do a little bit of an exercise. So I would get you to grab a piece of paper and a pen and jot down some thoughts, because I'm going to present a difficult conversation, and then I'm going to ask for some volunteers to give this student some constructive feedback. So I hope that you'll jot down some notes and phrases that you might say to this student. When I was preparing for the talk, I asked my other local preceptor colleagues what advice they had. And I learned a lot from them just asking the question. I'm going to show you a very short video. It's 6 minutes long. It summarizes the course of Crucial Conversations. It has a lot in it, and it's really busy, but I hope if you haven't taken the course, I hope it'll inspire you to take the course. I'm going to tell you what I've taken and used from the course. And then I'm going to go through 8 slides that are evidence-based guidelines about giving constructive feedback. My talk is 35 minutes long, so there's lots of time at the end for chat. Okay, this actually happened to me. So my student arrived at my clinic, first day, clinical clerk, high-heeled shoes, tight-ripped jeans, very low-cut silky shirt, large chunky gold necklace, crocheted long sweater that she kept readjusting and showing some of her cleavage. And my colleague pulled me aside and said, "You have to talk to your student. She looks like a prostitute." So I was like paralyzed by this situation. So I would like you to think about what you are going to say to the student. So I asked one of my palliative care colleagues what her best tip was as a preceptor. And she said what's been said by other speakers today: set up the expectations on day one. Come in with all of your expectations. She said that when she started teaching, she, because her rotation was palliative care and students thought that maybe this was a sort of soft elective and they're tired, they were going to take their sick days during her rotation, they were going to cut out early, they were going to, have a little bit of a rest during her rotation. And she, by being gentle at the beginning, she permitted that. And she said she's learned to sit down on day one with her students and say, I expect you to be on time. I expect you to take first call from hospice. I expect you to do the after-hour clinic shifts with me. I want you to be charting and dictating independently. And then when she started off like that with the really good expectations, then she could soften up and sort of work on what was naturally her way of communicating. So that was her advice. And I think that's really, really good advice. My other friend who teaches anesthesia, he said to me, the 2 times I've failed students, they were completely relieved. They knew they needed more help. They felt like imposters and they were super grateful to be found out. So he said that he got students that have slipped through and slipped through and slipped through, and they didn't have basic knowledge. And he was the only preceptor that failed them. So he was terrified to have that conversation with them. But when he had it, they were so, so grateful. So I think it's really important to make sure that you don't avoid difficult conversations. They're hard to have, but in the end, they really help your students be better physicians. And then he also told me you should state your strengths and weaknesses up front. Like, what's your style? My style is definitely focusing on communication and not so much on the hands-on skills. So I say to my students, like, if you're struggling with any of your physical exam skills, let me know, because I'm going to forget to check on that. So please, so point out your teaching style to them at the beginning. I think that's really, really important so that they can feel comfortable asking you to help them with something. So this is the video. Bear with it. It's busy. It has a lot, but it'll help you with the conversation you're going to have with this student.
Crucial conversations. Tools for talking when stakes are high will help you prepare and be at your best for those conversations that matter most. Conversations that can impact the quality of your life. The authors define a crucial conversation as a discussion between 2 or more people where 1, stakes are high, 2, opinions vary, and 3, emotions run strong. To begin with, a crucial conversation starts with dialogue. The authors say that dialogue is the free flow of meaning between 2 people, and those that are skilled at dialogue get all the relevant information from themselves and others out into the open. When the information, thoughts, and feelings from 2 or more parties is combined, it creates what they call a pool of shared meaning, creating synergy. At the heart of a person who is skilled at dialogue is someone who embodies the principle of work on me first. They start with heart, beginning risky conversations with the right motives, knowing what they want, focused, sticking to their goals, and not making either or choices. They always return to dialogue, like a meditator returning to the breath, by continually checking in with themselves with these questions. What do I really want for myself? What do I really want for others? What do I really want for the relationship? Then, how would I behave if I really wanted these results? People gifted at dialogue keep a constant vigil on safety. 2 symptoms that someone does not feel safe are silence and violence. Silence can be defined as purposefully withholding information from the pool of meaning. Masking, avoiding, and withdrawing are silence-related behaviors. Violence can be defined as any verbal strategy that attempts to convince, control, or compel others to your point of view. It violates safety by trying to force meaning into the pool. Controlling, labeling, and attacking are violence-related behaviors. The key is not to get caught up in the content of a conversation, and instead, when you notice these signs, make it safe again by reestablishing mutual purpose and mutual respect. When mutual purpose is at risk, you can end up in debate with symptoms such as defensiveness or accusations. If the other person knows we really care about their interests, this helps get you back to purpose. Mutual respect is needed to ensure dialogue continues. When people feel disrespected, they become highly charged and angry. A tool for returning to mutual respect is using a contrasting statement such as, I don't want to offend you, but I do want an improved relationship with you, to ensure what we say didn't hurt more than it should. As you move through the book, the authors say that people come to conversations with what the authors call a path to action. This path has 4 parts: see/hear, tell story, feel, and act. After we observe what others do, and before we feel some emotion about it, we tell ourselves a story. In our own heads, we can carry around stories that are based on faulty interpretations. If our interpretation is not rooted in reality, it is easy to retreat into silence or violence. If we take control of our stories, they won't control us. To change the stories you tell yourself, even in the middle of a heated conversation, retrace your path, going backward. Here is how. Act. Notice behavior. Am I in a form of silence or violence? Feel. Get in touch. What emotions are encouraging this action? Tell story. Analyze. What story is creating this emotion? And see/hear. Get facts. What specific evidence do I have to support this story? The best way to find out the true story is not to act out the worst story you can generate. There is a formula in the book called STATE, as in state your path, that will help you get down to the root of what is really going on. We go through it now. Share your facts. If you want to persuade others, don't start with your stories. Start with the facts. Take the time to think through about what your facts actually are. Tell your story. It's the facts plus the conclusion of your story that call for a face-to-face discussion. Do your homework so you can share your conclusions with confidence. Ask for others' paths. Encourage others to share their facts, stories, and feelings. Then listen to what they have to say. Talk tentatively. Use language that says you are sharing an opinion, not a nervous wreck. Tell your story as a story rather than disguising it as a fact. Soften it to add meaning to the pool, not force it on people. Encourage testing. Invite others to talk in a way that lets them know you are okay with what they have to say, even if it's controversial. Invite people with both words and tone that say, I really want to hear from you. This has been our review of the.
Okay, so that's a really busy slide, and there's a ton of information on it. And it is a 3-day course, and it takes 3 days to distill all of that. But the things that I have taken away from that course that I constantly use are the start with heart. So start with your intention. Your intention is to help the student be a better physician. And sometimes you have to say that out loud because they may not interpret your intention is that. So it's okay to say it out loud. Like you might say something like, I want to help you be the best patient interviewer ever so that you can get the story in 10 minutes. I want to make sure you don't miss any red flags. I want to make sure you have all the skills to be a good doctor. Start with your heart and your intention, and then the rest is easier. State the facts. We have stories about what we're observing. We have biases in how we perceive things. Try to say, what have I just observed, and only state the facts. They have to be said separately, and then you tell your story about how you interpreted it, and then you need to get their interpretation. So separating the facts from your story is quite a skill, and it takes a lot of practice. And then when you see your student maybe being silent or crossing their arms or it's not going well, then I always revert to, I don't want, I do want. And I mean, this really helps with your teenagers at home as well. This is where it's not going well at home, and you use the I don't want, I do want. So if I would use what Mike taught me today, I don't want you to learn how I think. I do want to learn how you think. So whenever you feel stuck, go back to I don't want, I do want. It's an easy thing to fall back on when a conversation isn't going well. So now I'm just going to give some evidence-based tips. This comes from the professional world, not just the teaching world. So the first one, and I, like Shayna, I'm a visual learner. So I've just done pictures, and I'm going to do a little chatting around each of the slides. So the I statements are a way to express your opinion by focusing on the situation rather than the person you're talking about. I statements begin with I feel or I think instead of you said, you did. When you use an I statement, you can make the feedback feel less personal by centering it around your experience. If you begin every sentence with I, you're constantly clarifying what you're sharing, that your thoughts and opinions rather than an objective fact. And then that leaves room for the student to disagree and explain why. So it opens the door for them to respond. You can help reduce the feelings of personal defensiveness that come up with any kind of criticism and make the entire feedback session quite a bit more productive. So you want your student to feel like the bottom picture. An example would be, I noticed you have a lot of text and not very many images on your slides. I find I spend my time reading the text on the page, which is distracting for me. What do you think about adding more images? So you state the facts, you state your perception of the facts, and then you open it to dialogue. But by using I statements, it allows a really good response. No poo sandwiches. Okay, this is this is something that they did when I was a student. They would give you a compliment, then they tell you what you weren't doing well, and then they give you another compliment. And this is terrible. It doesn't work. It hides the constructive feedback, and you can't focus on it. So this is it's been used for years and years and years, and it's really popular. But you really when you're telling someone that they've done well, it's just as helpful. So one of the key things I want to say today is give compliments separate from constructive feedback. Don't do them together. So make sure that you give, you support their learning and telling them what they're doing well, very separately from what they need help with. Okay, the feedback has to be actionable. So if you don't have a way in which the feedback you're giving can be acted upon, then you have to rethink about what you're trying to teach them. So you want to give them something to work on. You want to point out what can be improved, and you want to include ideas that they can actually implement to develop their skills. The best way for you to have actionable feedback is to make it student-centered. So you want them to create what the action could be, because they are more likely to understand what they're trying to improve and how they might approach it. And then so ask them what action they would like to take the next time they see a patient, and then add to that. If they've come up with the idea, they're much more likely to embrace it and run with it and try it on the next patient. Provide a safe environment. So this is really, really important. I remember as a student doing rounds, and you're all around the cart, and you've got your lab coats on, and there's all levels of learners. And the preceptor would say, "Now, Karen, tell me the Krebs cycle." And you'd just be paralyzed and embarrassed and ashamed and not ready for that. So constructive feedback always needs to be done in a safe environment, where one-on-one, it shouldn't be in front of the resident. If you're doing layered learning and you need to give constructive feedback to your resident, you shouldn't be doing it in front of the medical student. It needs to be done separately. And I think Robin touched on this in his talk. One-on-one constructive feedback is really important. I think that students also have to be ready for it. You can't have it come out of left field in the middle of a busy clinic. It's good to do it in a timely manner. And I think if you make a way of scheduling time at the end of the day. So what I usually do is I make sure the students aware that at the end of the day, we're going to sit down together. I have them sit in my big armchair with the arms, the big rolly chair, and I sit on a stool lower than them, because that instead of me being above them, it helps a lot. And body language, I have a whole slide on body language, so that's really important too. I have food in the office. So at the end of the day, sometimes the students are hungry, they're tired. I check in with them and I say, is this a good time for us to do some constructive feedback and some teaching? If they're exhausted, they've been on call the night before, they're not open to it, just leave it for the next morning or another scheduled time. So they have to be receptive to the constructive feedback. They can't be surprised by it, and it has to be in a super safe environment. Just be you. We're not perfect preceptors. A lot of my teaching is around what I do poorly. I point out that, I don't think I did that so well. How do you think I could have done that better? So just be you, just be real, be genuine. We're constantly learning. They're constantly learning. You can use yourself as an example of what not to do. And when you're real and authentic and genuine, then when you do say something, it's much more honored by the student. Disingenuous compliments, you can see through them right away. Even as they're coming out of your mouth, you think, that was not genuine. Just don't say it. The compliments and the encouragement needs to be 100% genuine. It needs to be real, and the constructive feedback needs to be really genuine. If you have a really amazing student and they're doing really, really well, and you're digging up some kind of constructive feedback for them, I don't think you need to give it to them. They've got it. So just keep working on what they're doing well and adding to that. Make it a dialogue. I love this picture. These are thoughts and ideas that are going back between two adults. These are adults. Your students are adults. They're wonderful people. They have a wealth of experience. They have a lot of experience of other situations that you may not know culturally, philosophically. When you make it a dialogue and there's lots of back and forth, you learn, they learn, you both grow. And I like that vision of you both being trees and you sharing the ideas, and you're both actually growing from the experience. I love teaching just for this. I feel like I learn way more from my students than I teach them. So, so when it's a dialogue, that happens. It has to be timely. So the literature says it has to be before 7 days. People forget what happened. Your perception of the facts are skewed with time. Their perception of what happened is different. If you guys aren't working from the same page of what happened, it's pretty impossible to have a constructive dialogue about it. So that's why I think you have to have a little space almost every day that you have a student to make sure if there's something really critical that happened that day, that you say it that day. And if they're too tired or hungry or have to go home, make sure you're saying it the next morning. Because if it's too far away from the event, it's too skewed. And you know what happens to preceptors is often they do their first really good constructive feedback on the 2-week evaluation. That's too late. That's way too late. They haven't had time to hear it and correct it. And then maybe they only have 2 more weeks with you, and they get another evaluation. The constructive feedback has to happen on a day-to-day basis. And I think if it's happening on a day-to-day basis, it becomes normal. It becomes normal of the day. It becomes okay. It becomes acceptable. And the student, it becomes very used to it and not shocked or ashamed or reverting to silence or violence when they hear something that's hard for them to hear. So if it's just part of your day, then I think it becomes really receivable. This one is the one where I learned when I was doing I spend so much time thinking about what my words are going to be for my constructive feedback. I practice it in front of the mirror as I'm driving to work. I'm practicing what I'm going to say to the student. I'm thinking about my words, but your words are only 7% of what they're receiving. It's your body language and your tone of voice. And so, you know, if you cross your arms to be comfortable, you have to check yourself. How you're sitting, as I said earlier, is really important. Your tone of voice is really important. The body language, I mean, I don't even believe this slide, but apparently this is the science. And so I'm really checking, are my legs crossed? Where are my feet? Where are my hands? Where am I sitting? What does my voice sound like? Because I really thought it was all about the words, but a lot of it is about your body language. So I think really check how you're sitting, check what's happening, just check in with yourself a lot. Like on that crucial conversations course, they say, if you're checking in with yourself regularly, just like when you do yoga and you do your deep breaths, like make sure you're checking in with how you are presenting yourself to your student, particularly when you're giving difficult, constructive feedback. So that was short and sweet. I wanted to leave some time for people to practice what they would say to this student. When I presented it to one of my other preceptors, who was a male, he said, I wouldn't touch that with a 10-foot pole. So he said, I would have said nothing. So what does anyone want to give it a go? What should we say to the student? Anyone?
I won't.
Karen, it's Jeff here. I agree with your colleague. This is so politically charged. I feel like it's a no-win situation, no matter what you say. Yeah,
it's a really hard one, isn't it? Yeah, Shayna.
I won't bite for the student part, but I will say that I feel like I want to talk to my colleague too. And that's also anxiety provoking, that there's something that's not going to sit well about, like, I respect their concern, but the comment also is a bit out of bounds.
This was a really challenging one for me. And, but these are the situations you might run into with students. You run into complicated conversations. And, you know, on the one hand, I think it's really important that the student does learn well, body language and how you present yourself and how you dress is actually important. But it is politically charged, and it's very different for me as a woman to talk to her about how she dresses versus a male preceptor. And so there's cultural stuff, there's gender stuff, so we get thrown into some pretty difficult conversations. Daniel?
Hi, I think, in a situation like this, maybe there is nothing inappropriate. That's kind of a values judgment on how we dress and things like that. So in this specific example, I think it's about, what is appropriate for the environment that we've set, right? So it'd be more so not what you're wearing is wrong, but more so, in this working environment, we ask that people do why, you wear scrubs in an OR, you don't wear jeans, right? So I think that's the way would be the most positive of framing it in a kind of, challenging no-win situation, because it's entirely values-based, right? But, ripped jeans may not be the best choice if, you may come in contact with bodily fluids, right? It doesn't provide you proper coverage, things like that, right? So more from a practical, what we need to get done to do our job purpose, rather than a values loaded discussion about something like that.
Fantastic. I agree. So you have to come at it with an angle that isn't about dress in general, and it isn't about, it's about maybe safety in the office, like high-heeled shoes and running during a code or some kind of emergency. So you might take the safety. I love that. That's a great way to approach it, from a safety for her, concern for her. Like, I wanted her to present herself as professional to my patients. And so that's the conversation I wanted to have with her. And I definitely struggled with it. Does anyone want to give a go at how you would have a conversation with her from presenting herself as more professional?
I had the same situation, although I'm not a physician and I'm an administrator, but I had the same situation with somebody who worked for me in an office, in the dean's office, actually. And I did present it as a profession, not coming across as professional. And interestingly enough, that person right away recognized that. And I think they knew, and they actually appreciated me telling them. And didn't seem surprised, and actually didn't get offended. Sort of went, I get it.
Yeah.
And changed, and actually it was okay.
Yeah. And so what language did you use, Chris? What did you how did you say it?
Well, I worked that we were in an area that required us to be presented. We present for the dean. We get a lot of people in this office, and we like to present ourselves professionally. And what she was wearing it didn't come across as professional. Luckily I didn't have to go into too many details, because like I said, I think she got it right away. She did get it right away, and she admitted, she kind of went, I get it. So anyways.
Gistahorn?
Hi, Ogisto. Yes, I find this such an interesting discussion, because I run into this all the time, not so much in terms of somebody's dress, but their general perceptions and unconscious bias that they may bring into the forum, into the room, and to the encounter. And I have a really, really hard time dealing with it. So I will be talking about it in the discussion following. But this is really important, and trying not to save face, which is a huge cultural ethic for us. So you kind of be indirect, but then how do you know if they got it or didn't get it? And that's the problem, because if they don't get it, meaning they don't have the ability to find insight, humility and insight, and then change, then what are you supposed to do? And maybe it's too late and you're at the end of your rotation. And so, or even after. So I think it's really important to be able to balance the indirect with the direct, because sometimes either or doesn't work. Anyway,
Yeah, I
really
agree. And I didn't have a relationship with this student yet. This is her first day. So she didn't trust me or know me. I didn't trust or know her. I don't know if she got locked out of her apartment and she couldn't get her clothes. So I think there's so much that could have been behind it. Does anyone else want to give a go at what language they might use to talk to this student?
I think that I might approach it saying that it's important that you look the role of a doctor. I mean, I was always dressed up to go to work, and I think you get a much better reception. Your patients think you look like a professional. I mean, if you go to see a lawyer and the guy's sitting there in jeans and a t-shirt, you're going to go, what the heck? I'm paying you $200 an hour. You should be wearing a three-piece suit. Because even though we try and say, oh, it doesn't matter what you look like, I think perception and what people's first impressions are very important. And I would say, look, you're young and people have perceptions that you want to look like a doctor. You'll get much more buy-in from your patient.
Mm-hmm. Yeah. So I care about you. I care about how patients perceive you, rather than what my colleague said. Yeah. But that is actually how some of the patients might see her. So I think saying, I care about how you present yourself. I care about what the patients think about you. I care that you present yourself as a professional. So you could use that kind of language. Anyone have another angle, a different way of talking about it?
What I probably really would have done was ask my nurse to talk to her.
Got it. Who are also part of the teaching team, by the way. Jeff?
Now that I've had a chance to reflect on this a little bit, it seems to me that this is part of the conversation you would have about expectations, as the orientation process. And it doesn't have to be isolated as a single thing, just as a package. These are the expectations we have.
I love it. Perfect. Because that was her first day. So I could have just rolled it into, and I expect you to wear a lab coat or scrubs or, yeah, exactly. Good. I like it. Melissa?
Yeah, I think sort of along the same lines as what others have said. In my mind, I was just thinking, I'd say, I just want to make sure that you get the respect you deserve from patients. And some of my patients are a little older and might have some of their own biases. Is it okay if I make some suggestions about, how you might present yourself? And, not necessarily say, this is how you have to dress.
Right.
But can I just make a couple of suggestions to make sure that, people aren't distracted and really, again, give you the respect that you deserve so that you get the most out of these interactions.
I love that language. That's amazing.
We do casual Fridays sometimes, like as an office with our staff, we'll sort of say, hey, okay, it's okay if everyone wears jeans on this Friday. I know some offices do it as a fundraiser for United Way, and but there's sort of an expectation with all the staff in our office that we step it up on the non-jean days of it.
Yeah, that's really nice. So getting the respect you deserve. I like that. That's really great. And anybody else have a way of talking about it with the student? Laura?
I would just echo what Melissa just said as well. Like you could maybe I take it back upon myself a little bit, and I'll use words like, well, this is what we expect in this environment. And it's just sort of not it's sort of, well, this is just what I expect. And so when you're here, we would all appreciate this is how we've conformed to a sort of a business casual, and sort of, I can, almost make it my fault that, but that's sometimes I do that maybe to a fault. But for this particular situation, I think it would maybe offload a little bit sort of onto me. This is what I expect. You might find it different in another location, but if you could while you're here, sort of thing.
Yeah, and you're using the I statements, which does open it to them to be not personally insulted.
Yeah, it just takes, exactly. And I really liked your point in the beginning, the use of the avoiding the use of you, because it can be very confrontational. And I've used that strategy many times, really take the pronouns out of it and just make it very much a bigger conversation that way, and not just sort of the two people in the room type of thing. So yeah, thank you for today. It was really great.
You're welcome. Jeanette?
I like those suggestions about, pointing out, this is a professional environment, etc. I guess in my office, some of my colleagues do dress relatively casually. So I'm not quite sure what I would say if my male colleague down the hall in the summer is in there in shorts.
Right.
What do I do then?
Yeah, good point. Yeah. And then maybe you would frame it around, as a student, once you're out on your own and in your own practice, you can dress how you want, I guess. I don't know what you would do with that, because that is tricky, isn't it? And this is gender laden, right? So you have to be really careful not to somehow a low cut blouse is different than a man wearing shorts.
Oh, definitely. And I think of a situation where my parents had to see a particular specialist who was female and who came in tall boots with high heels and a shortish skirt. And they both picked up on that and were like, oh my God, what is she wearing?
Yeah.
And I did sort of think, now, if she was a man, would they be looking at that?
Exactly.
I mean, there are so many gender layers to it. And so you are caught in a very challenging situation.
Mm-hmm. Mm-hmm. Yeah, Melissa.
Just to add on, I think one of the things though, with it does make it really difficult when there's sort of discrepancies in how people present themselves in the office. But I think with your colleague, I'll make an assumption that, he's maybe been in practice for a little while. He's already got that relationship with his patients. That respect is already there and established. And so going back to a new student who's just coming into the office and really hasn't got any kind of relationship yet with the patient, hasn't sort of established that respect. I think that's sort of how you could kind of go about explaining or establishing that expectation there. He's already got that trust with them, so they're okay if he's in shorts. They're still going to respect his opinion as a physician. But this is, you've got to make your first impression and kind of earn that trust.
Mm-hmm. Very good. Natalie? We're finished.
So I was gonna say, I don't want to cut off the conversation because it's so wonderful. But just wanted to give you a moment to sort of, if you had any other closing thoughts or sort of a minute or two to wrap up or final comment before we move on. But this conversation has been really quite wonderful, and particularly this case example, I think. So thank you. I'll pass it to you, but I just did want to be mindful of the time.
So I'll tell you what I did. Nothing. I was paralyzed. I did nothing. And the next day she came dressed perfectly professionally and the whole time through. So I think what happened was she came to our office, she saw how everyone else was dressed, and she quickly adapted. So I guess sometimes you don't have to say anything. You give your learners a little bit of opportunity to right themselves. I think if she came dressed that way the second day, I would really have to say something. So, but I didn't say anything because I was paralyzed and I didn't know what to say. And it turned out okay. And so actually it taught me that lesson that maybe you just need to give students time and space to pick it up themselves. Anyway, thanks for listening, and I hope you enjoyed the talk.
Thank you so much. Karen, and I will pass it over now to our final speaker. We're very lucky to have Dr. Ogisto Horn joining us from the Akwesasne Medical Clinic to speak to cultural considerations for trainees working in Indigenous communities. So I think we should be ready for you to share your slides, and I will pass the remainder of the morning over to you, and then jump in at the end with a few final comments.
So thank you very much for this wonderful discussion. I really enjoyed what I was just hearing by Dr. Euler, and so in any case, I'm here to talk to you about some lessons learned from working, or lessons for learning in an Indigenous community. My name is Ogisto Horn. I'm from Kahanawake, which is a Haudenosaunee or Mohawk community near Montreal. My mother we're Bear Clan. My mother's from there. My father is from Akwesasne. He's Wolf Clan, and I've been working in both communities for about 7 years each. I'm now working in Akwesasne, and I'm here to talk to you about some of the lessons learned by teaching trainees from Queen's, McGill, and the University of Ottawa who come to Akwesasne. So I wanted to just say at the very onset, I come from a huge background of health care people, and these people are all in my family, and their stories have filtered down to me about how they did their works as plant-based medicine, as knowledge keepers, traditional medicine knowledge keepers, political leaders, as bone setters, as midwives, and of course as administrators, even recently in our facilities. And so I always like to acknowledge this incredible girth of knowledge that my family has given to me. The objectives today are, very quickly, I want to talk a little bit about the jurisdiction of our community, talk about primary care in our community. I want to talk about the history of our elective. I want to talk importantly about the supervisor and trainee relationship in our community. And then I want to talk about ways, Haudenosaunee or cultural ways of introducing the students to the community, providing teaching, feedback, and ways of evaluation. So very early on in the 1600s, there was a relationship between the Dutch and the Haudenosaunee, which we call the Gaswantha or the Turo Wampum. And in this particular treaty, it's a way of interacting with other people, and other nations, other groups. And basically what it is to keep is the maintenance of will, to be able to say, I'm going to do everything to preserve your will. I'm not going to crush you. I'm not going to humiliate you. I'm not going to overrun you. I'm not going to micromanage you. And that's really the way that it's a huge cultural ethic that is the current underneath almost everything that we do in our communities without ever explicitly saying so. So our community, first of all, I wanted to just do very quick to talk about why we are where we are in Akwesasne, which is right on the border of Ontario, Quebec, and New York State. So in the Treaty of Paris in 1783, this is after the American Revolution, they did this line that was sort of just arbitrarily found or determined from Paris. And it's at 45 degrees would be the delineation between the United States and the Northern British colonies. Now, the 45th parallel is halfway between the equator and the North Pole. And so we just happened to be in that area. But then in 1791, a little bit later, after the American Revolution, loyalists went up north, and Lower Canada and Upper Canada became delineated, which is part of the colonial history of Canada. So there was a border between Upper and Lower Canada, and in that space between Upper, Lower Canada, and New York State, that is where our community of Akwesasne sits. In 1794, we have something called the Jay Treaty. And in that, when they first put that line, when they were doing the surveying, our people were like, well, what are you doing putting all these survey tools and going through the community. And we were told, don't worry about it. This line, it goes right through here. And at the end of your community, it goes up 8 feet or 10 feet, goes over and comes down on the other side. There's no border for you. We said, great. Well, anyway, so this is the treaty that confirms that. And of course, underlies most of the relationship that we have between Canada and the United States if you are an Indigenous person. Later on, the British North American Act from 1867 described the mandates or the power of both the federal and the provincial governments. And the important point in there is that we're talking here about provision of healthcare, primary care, which is actually a provincial, as we know, a provincial mandate. But when we're talking about Indigenous community, we're actually part of the federal government. And that's because of the Indian Act of 1876. So this Indian Act continues to this day. There have been many, many changes to the Indian Act. And a lot of them have been very difficult, but we've had to live under this. So this defines our status. It says who we are. It defines how government is administered in our community. So of course, traditional government was removed forcefully in many of our communities, particularly Haudenosaunee communities. And it talks about the management, describes or it outlines the management of our lands and communal money. So pretty much who we are, how we conduct ourselves, and how we can have a relationship with the land, and who is in charge of our money are, some basic things that run everybody's lives. And in our case, it is the Indian Act. So, like I said before, this is a map of our community. And so if you look, of course, the orange is Akwesasne. Cornwall Island is in Ontario. All those islands in the St. Lawrence River are part of Quebec. Some are in Ontario, but mostly in Quebec. And the two peninsulas going into Quebec from the American side of the community are St. Regis and Snai. And so it's a very complicated jurisdictional area. And so we started with a rural elective in 2017 with McGill undergraduate in family medicine. In 2018, we started to host family medicine residents from Winchester Hospital. And then in 2018, we started with Queen's undergraduate medical medicine for for a rural placement, which is through the work with Shana, Dr. Watson. So Guanaguatsurio, which is the Good Medicine Clinic, is physically in St. Regis in one of those peninsulas in Quebec. It's called an Aboriginal Health Access Site, and this came from the Royal Commission of Aboriginal People. It was a big study done in 1990s, which described the best way to provide medical services to Indigenous people is to put everything in one spot. We have a lot of problems in our communities, and going from different types of clinics all over is very difficult for many people. So let's just put everything in one spot. Now, in our particular clinic and in most of these AHAC sites, you have a number of services, but there are also affiliated services. So the entire Department of Health, we have a holistic medicine program, which has the medical clinic, the traditional medicine clinic, the mental health and addictions workers. We also have a diabetes team, family and child services, a community health nursing program, which was really involved in the provision of information, vaccines, as well as testing for the COVID pandemic. We have two long-term care centers, one in Ontario, which is a 50-bed facility, and one in Snai, Quebec, which is a 25-bed facility. We have home care and community health nursing. We have non-insured health benefits. And then, of course, non-insured health benefits is something that is specific to Indigenous people. It's part of the medicine chest, in which things like dentistry, optometry, pharmacy, medical devices, medical transportation, and medications, pharmacy would all be part of the medicine chest, and it would be provided through this program. non-insured health benefits, which is part of Indigenous Services Canada. So it's separate from the healthcare, the provincial provision of services that non-status Indians obtain. We also have an ambulance and a paramedic service. So the rural elective in Akwesasne was particular because it was premised, it was actually started by myself. We have very few family physicians and specialists. So when I started it, and for the first, well, actually right up until now, I've been one of the only family doctors who has been affiliated, who has done this. I did it on my own, having recognized the importance of providing opportunities for students, trainees to come to our community. We have there's so much interest in and there's so much need to improve primary care in our communities, but how can you really know that if you don't have any experiential learning? Didactic is very good, going to seminar is very good, but you have to be on the ground to actually really understand, you know, how primary care is provided in an Indigenous community. And so we do have allied health professionals, like I said, non-insured health benefits, and we have lots of different structures in the community that provide language learning, history. We have many sites. We have, like I said, the clinic for medical care. We have home care, long-term care. And so typically what you see in any kind of rural site is you have one site and it's very clinic oriented. But because I was the only doctor, I felt like I couldn't provide the big scope of Indigenous health, community health, but just by having the student follow me and work with me. So what I did was I went and worked with all of the different health professionals and the different programs, as well as language and history people, knowledge keepers, and created a program that was really based in community medicine. So I didn't see them 100% of the time. And that worked really well until the pandemic, when, you know, everybody went home, everybody was working from home, and I was working in the clinic, and I couldn't keep this up because there was such a gaps in services because of providing trying to meet all the mandates of the COVID pandemic. And so that stopped. And it was unfortunate because when students came to the community, I made sure that there were opportunities for them to, at least see many different parts of our community, things that you as a person who is coming to our clinic wouldn't necessarily see. You really only, there's a bias. You only really see the sick people in the community, people who are unwell, who are unbalanced, who are, falling through the cracks, or, can't, who have multiple comorbidities. You're not seeing our young people, our traditions. You're not seeing our healthy young people playing lacrosse. There are some very important, very, very well organized businesses in our community, like our casino. So basically it was really important when our students came to the community, they got a really big picture of how the community works and how the clinic is just one tiny part of it. So when people first came to the community, it was really important to do a tour. So I would give them a full day tour, and part of that tour required them going on to the radio. And so we have Dr. Wiseout here. She's one of our new doctors who came back to the community. She was a resident and then she came back, and now she works full time in our community. And what we did was with all the students was, go onto the radio, and the student would be asked a number of questions from our radio DJ, and people were always listening because radio is the #1 source of information, particularly to the older folks in the community. And describing who they were, why they went into medicine, how they ended up in Akwesasne, what their future plans were, what they thought about our community, that kind of thing. And so, it was really like just an introduction, which was felt to be very respectful. And so when these trainees, went about and they were in the community, people would say, hey, yeah, that's you. I heard about you. I heard you on the radio. And so it was really important for the community to know who was in the community. There was an importance for the student to know that they were being that they just didn't walk into something and nobody knew who they were or what they were doing there. So it was really important to properly orient the student to the community and the community to the student. Now we talk about social determinants of health. This is Dahlgren and Whitehead's model, and this is something we all, have learned about in our training and of course in our work. And so all of the I've been trying really hard to show the students about different parts of our our social economic fabric of the community that really imparts upon our health. But one of the things is that we don't really capture the parts of our community that are really the fabric of the community. So the things that I mentioned, buildings and businesses and powwows and fairs and all that stuff is very material. You come through there, you can see it. You can see all our cigarette shops and our pot shops now. You can see all that stuff, but the stuff underneath, which would describe, our oral tradition, history, worldview, our networks, our traditional knowledge, languages, our storytelling, the way that we look at the land, the way that we function, our government systems outside of the government, how we relate with other people, that's not really seen. And that's the crux of when you come to our community, that's what you really do learn when you are here, immersed for a long period of time. So I'm not going to belabor this, but there is a different worldview that many Indigenous people ascribe to, and it's very relational, and there isn't a hierarchy, and there's an acknowledgement of all the different moving parts working together towards a common goal. It's a very different, and it is manifest in the way that we teach, the way that we evaluate, the way that we conduct ourselves in the community. So I want to talk very quickly about something that I think is the most important part of my discussion today. And this is with relation to what happens at the edge of the woods. So traditionally, our communities were, Iroquois people or Haudenosaunee people, which are the people of the Long House. We lived in the area in the Adirondacks, all the way north and just north of the St. Lawrence River, and we lived in these communities where there were like sometimes 50 families in each longhouse, and our communities were built kind of haphazardly. They weren't built in nice rows, and if you were not from the community and if you came into the community, you wouldn't actually know where to go because we would have it blocked off like a maze. And so if we were ever attacked, we could actually find you and make sure that you didn't leave. So there was a huge strategic reason for the way that we had our longhouses built with respect to one another. We also had a palisade that went right around the entire community, and outside of that we had like the fields. We were agricultural people, so we we're very much, we have our three sisters, our corn, beans, and squash, our tobacco. We were very much involved in the agriculture. We also were fishermen, and at the very edge, the space, this liminal edge, was called the edge of the woods. And so if you came to the community and you were somebody who was from there, you would go to the edge of the woods and you would sit there, you would light your fire, smoke your pipe, and you would wait. And then people from inside the community, there would be somebody there, they would see you and they would eventually come out and greet you and see where you'd been, how you're doing. And if you were carrying, like, let's say you just come back from a battle or a fight, or something really grievous had happened and you were carrying a lot of negative energy, we actually had a ceremony to brush you off, to acknowledge the trauma that you'd been through, and to talk about it and to brush it off. And that was called the small condolence ceremony. And then once you were okay, then you would go into the community. And that's if you were from there. But if you weren't from there, you still would go to the edge. The protocol was you would stay there until somebody came out, saw you, sat with you, and then, who are you? Where are you from? And what's your business here? And that actually is something that you see throughout Indigenous country across North and South America, particularly North America. So if you work with Indian people or Indigenous people, you'll hear them commonly meet another Indigenous person and they're like, so what's your name? Where are you from? Who's your mother? Who's your father? And you basically are trying to figure out if you have a relation, and you go back and you find, and eventually you find, yes, we know so-and-so from, some other place. And you establish a connection, a relationship. And I remember as a child listening to my mom and being like, oh, this is taking so long. Why are we doing this? But in fact, it's how you remember people. Oh yeah, I remember you. You were so-and-so, or, I saw you at so-and-so. And so it really creates a relationship. And so when the person came to the edge of the woods and they described who they were, and there was a relationship established, and then the question was, what is your business here? Maybe they would hold a wampum that, they're here for an act of diplomacy. They're coming from somewhere else. And so that person, once it was established that they were not, an enemy, or they weren't going to cause harm to the community, they would be brought into the community. And then in the community, behind the palisades, and not all villages, but many villages, there was a space that was for the public. And so you would go there and that's where you would be. If you were to go further into the community, beyond that area, you would have to be brought by somebody, and that person would bring you in, and they would be basically your sponsor. And that sponsor would be responsible for everything that that visitor did. And so they wouldn't be found walking by themselves all throughout the community, between the longhouses, going in and out of the longhouses. No way. There would be a sponsor with them. And anytime something would happen where maybe that person was doing something that was not right, if it wasn't too egregious, they would actually tell the sponsor, and it was the sponsor's responsibility to tell them to change the way that they were behaving and that kind of thing. So we're not very good at directly telling somebody what to do. We usually do it very indirectly. And the sponsor, and we tell the sponsor, and that sponsor is responsible for telling the student or telling the trainee. In this case, we're talking about trainees. So they're at the edge of the woods. They're brought in by me. I am their sponsor, and I make sure that they safely go the way that they go through the community. And anything that happens in the community comes back to me, and it's my responsibility to tell that trainee about what happened. So this was never made more apparent until recently. We did have some problems with a trainee who actually did not conduct themselves well and was never aware. Nobody ever said, hey, what are you doing, or why are you talking that way, or you shouldn't be saying this. No, but they laughed with him, and they just didn't encourage him, but they kind of respectfully let him say his bit, but they didn't say anything. And it was only after he left our community to go back home where they came and told me, and then suddenly he was already gone, and I had all of this other information about how he had conducted himself in the community. So I didn't have the opportunity to sit there and talk to him about what had happened. And so this is a really important point. When you come to our communities, you have a sponsor. That sponsor may not always have all the information until after. So, and that was a problem. So one of the things that we do when the students come into our communities, the residents and the medical students, we encourage their autonomy. So we're not very good at telling you exactly what to do. We don't micromanage you. What we do is we allow you to, find your way, find your space, be comfortable, and do your work the best that you can do with some guidance, but not very much. And of course, our job is to sort of help that person get through with saving face, making sure that they feel that their will has not been compromised, and that they learn from it. They get some insight, and they have some humility, and then it changes their action. Like what Dr. Euler just said, where you provide time and space to pick up the problem themselves. So that's actually very, very, very much how I teach. And in some cases, the residents and students may feel that that is a little bit too permissive and they're uncomfortable by it. But it's the way that I teach. I cannot manage, micromanage my students. And so I think what I have learned is that I have to really state at the beginning, I'm going to let you have a lot of autonomy, but I'm going to be watching and I'm going to help you. But don't be disturbed and think that I'm not paying attention, because I really am. It's a cultural ethic that I am performing, or in terms of education. It's how we educate our young. It's actually one of the reasons why a lot of our children were removed from our care. They felt that a lot of Indigenous people were too permissive with their children, and they didn't understand that this was our way of teaching our kids. We're very narrative. So if you talk to an Indigenous person who grew up with their language, you will find that they're very flowery, and they may take a long time to describe their symptoms. There's a story attached to it. And this is the way that we interact with one another. It's very verb-based. And that sounds interesting, but a lot of the Latin languages, the Romance languages are not verb-based, they're noun-based. So when you're describing something, you'd start with the word, the pronoun, like, I was walking down the street, and then this happened, and then the environment is then described. Whereas when an Indigenous person is talking, if they come from their language, they describe all the environment and what was going on, and then they put themselves in it. And so you have to wait to find out what their place in that story was. And so it can seem very verbose. It can seem very, very tangential. It can appear very circumferential, but at the end, you get a really good idea. You get that story. And sometimes it doesn't take 10 minutes, but if you can get it in 10 minutes, that's awesome. But we do have a lot of people who may seem like they just can't get to the point. A lot of Indigenous students, when they go through medical school, have this problem. When I was in internal medicine, I had an incredible difficult time trying to get to the point. I remember my supervisor just like snapping their hands and banging their feet, like, oh, just get to the point. And I was like, I can't tell you this because you don't know this and you don't know this. It was incredibly uncomfortable for me to describe, to do the case report if I couldn't do it the way that I had learned throughout my life. And I had to unlearn that. And I realized, okay, and I would say, yeah, this is a 85-year-old person who comes in with shortness of breath for 4 days, and it was found, and when I did it that way, she was like, yes, that's exactly what I want to hear. And I thought, wow, that was a terrible presentation. But it actually, when I figured that out, I started to do much better in school. So we have very different ways of describing something, and Indigenous people and Indigenous students may present that way, and we have to be aware that it's not that they're not smart. It's not that they just can't get to the point. They're being very respectful, and it's based in their language that they're trying to explain or answer your question. And so one of the things that I've tried to be for the students is to let them recognize that our patients are maybe a bit more verbose, and that I am more permissive, but we do need structure. And so one of the things that I've started to do is is have the medical student and residents to actually talk about, like to actually state like an identifier, and then what was the learning point. And there's many learning points that are not necessarily medicine, they're actually communication. And I really stress, I really want, when they say something or they learn, I said, I want that to be a learning point. I want you to really think about it. The other thing that I do is when I'm teaching, I may not tell them directly what I think that they should or shouldn't do. It's too micromanaging. I will tell them a story, very much like my the way that I just described. But I'll tell a story, and then what I wasn't doing before, which I have to do now, having gone through this this conflict with a recent resident, I realize now that I have to be more explicit. So now I'm like, I'm telling you a story. I want you to think about it and see how it relates to what your encounter was. And I'm going to ask you tomorrow what it means. So I'm trying to give the opportunity for that resident or student to think about why I said this big story, and then to let's talk about it tomorrow. And that maintains both the rigor of the Western way of communicating and learning with the Indigenous way. Let me see, yeah. So the moccasin telegraph is super important. And this has to do with when you come to one of our communities, you actually aren't anonymous. And a lot of people don't know what that means because they've always been anonymous. If they live in a city and grew up in a city, you can be reasonably assured when you go from A to B that most of the people that you're going to see as you're making your way from A to B, you will never ever see again. And I find that incredibly stressful, knowing that I'll never see these people again. So I'm not a city person. In a community, everybody knows who's from there, and they've seen them before, and even the way they conduct themselves, you're like, you're not from here. So so it's really important for those students and trainees to recognize that they are not anonymous, and that people are watching and people are listening, and they're not going to be told when they're doing something wrong, but definitely I am going to be told. And it's a super important, recognize that you're a visitor in our communities, and conduct yourself as the most respectful that you can think of, and just be aware that there may be incredible opportunities to think of privilege, unconscious bias, find insights, get humility, and try and change the way that you interact with Indigenous people. So the CanMeds is something I'm sure everybody is very aware of. The family medicine CanMeds that was written in 2017 was rewritten by a group of us with the College of Family Physicians of Canada, the Indigenous Health Committee, of which I've been on for many years, and rewrote an Indigenous health supplement. And it's basically looking at all the different 7 parts of the CanMeds, but putting an Indigenous spin on it. And it's a living document, meaning it's always changing because we're always putting new references, etc. And we're trying, and unfortunately, it has to be cases to be able to really explain how this works, and through stories, and through really encouraging reflection and humility. And so all these things I've described are the way that the CanMeds works. That's why you can't just get a story, get a didactic teaching and then be able to just carry it out, because there's a lot more involved, and we're trying to get the essence of that in the CanMeds. And you may hear us all over the place talking about CanMeds, the Indigenous supplement. So I would encourage you, if you ever see us at FMF or some other place, come in and have a listen, and you will hear some of the things I've described today in action at those forums. So thank you very much, and I will stop sharing my screen. Does anybody have any comments or suggestions? Yeah.
I'm just going to say thank you, Dr. Horn. We do have time for a couple of questions if there's anyone that has any questions or comments for Dr. Horn or any of the other speakers. That was a wonderful presentation, so thank you so much.
Yeah, it was really great. I was just thinking, I've been working at a refugee clinic for about a year. And I was thinking what you were teaching me is really applicable to many Indigenous cultures. And many different, like we get people from Somalia and Syria and Eritrea, and what you were saying about the story, I've really had to change how I get a history. And the stories are fascinating. Like it's just nice to sit back for 5 minutes and listen.
Yeah. And it's not a negative thing because you remember it. You don't remember all the little, stuff about their heart failure and but what you remember is the story. And then you're going to remember that person, and they become a memorable person instead of just a patient. And so, yes, I agree. Unfortunately, we've lost a lot of that in Western medicine because of the element of time. We have to do so much in such a little amount of time. That's why it's so hard to provide medicine or primary care in our communities, because you need so much time, and the fee-for-service model is so difficult to do. And so I appreciate that comment. Indigenous people come from all over the world. So I guess there are no more questions. Do you have anything to say, Shana?
Thank you so much, Gisto. And this is sort of on the eve of another integrated student coming to live and work with you in Akwesasne, and that experience of being welcomed into community is so meaningful for the students, and the immersive experience. They are challenged and given the opportunity to learn in so many different ways, in so many different domains, that it engages like their whole personhood. So thank you for this, and thank you for your work with our students.
Oh, yes, I love it. I love it. Having a student in your community for 3 months is an incredible gift. You learn about just about everything about them and how they respond to stress, how they interact with all different kinds of people, their knowledge of Indigenous, history and health and politics. It's just so incredible to see them just like bloom. Which I don't know if you get that. I know I never impressed any of my supervisors, when I was in medical school and residency, because it was such a tiny little bit. So I really enjoy the opportunity to teach residents and medical students for these extended lengths of time.
Yesterday, Connor said to the new students, he said, on a regular rotation, you're expected to fit into the system. But when you're on an integrated, the preceptor tailors the experience to you and helps you grow.
Oh, that's wonderful. Yay, Connor. I really would be interested in taking this course, the Critical Conversations course. The reason I'm saying that is because I actually have a very hard time with critical conversations because of this about trying not to impose, trying not to tell things very indirectly and hope you get it. Our indirect approach. You may see this in a lot of movies, and there, you've got the wise Indian man who says something but doesn't say anything, and the person is really confused. That's really how it is. And so we're not very direct, and we're expecting you to think about it and figure it out and change the way that you are. But a lot of people don't get it. And if they don't get it, then I got to do this difficult conversations course, because I unfortunately could not know what to do with a previous resident. And I think that I would love to be able to marry the two approaches so that I can be able to recognize when they won't get it and know how to approach it otherwise. So it's once again marrying traditional approaches, cultural approaches with Western medicine and the Western culture together to be able to provide the best care and the best teaching opportunities for both our community members, our patients, and of course our trainees.
Wonderful. Thank you so much. I might just take a few final moments here and wrap up for the day, for the morning, I should say. So a thank you to all of our presenters, Dr. Horn, Dr. Watson, Dr. Kenny, Dr. Ward, and Dr. Euler, who really led us through a wonderful morning and some really, really great talks. So thank you for sharing the important topics with us today. Thank you to all the attendees who were able to take the time to join us. It's really appreciated, and we're really happy to have you here. And thank you to the planning committee who made this all possible. As I mentioned, it was a big partnership between regional education, the Office of Professional Development and Education Scholarship, and undergraduate medical education. So a big thank you to everyone. As I stated earlier, we will be sharing this recording and hope to be sharing more resources. I know we had talked about the references and all of that following this session, as well as some really exciting upcoming additional educational resources around flipped classrooms, navigating Elantra, anything else that you would find useful. So please don't hesitate to reach out at any point if you do have something on your mind or something you think would be helpful to you in your clinical role. The last thing that I'll mention is when you get the email from us, there will also be a little space to provide feedback on today's session. So I'll dump the link in the chat right now, but you will get it later as well. And that's just to evaluate today's session and provide us with some feedback. So we'd appreciate it if you take a few moments to fill that out whenever you have the time. And with that, I probably would, maybe I'll pass it over to any of the regional education folks, or Shana, if there's anything you would like to add as we close out the morning.
Just filled with such gratitude for everyone who spoke today, and that everyone who attended, for taking the time for the beginnings of these really meaningful conversations.
And if I can just add, on the behalf of regional education and Queen's University, thank you so much for this phenomenal presentation. Thank you to all the speakers, and we really look forward to working with you in the future.
Thank you, everyone. With that, I hope you have a wonderful day, and we're just about right on time, which almost never happens. So I hope you have a good afternoon and a wonderful weekend. Thank you all.